the continued participation of the Department of Health, the main architects of this bill, so that they could listen to the comments of what our public institutions are saying in this matter. May I then request Ms. Majalamba to give an update on the attendance register and the apologies of any of the honorable members, if there are those that have apologized.
Morning and thank you, Chair. Present is Dr. Dlomo, Mr. Munyai, Ms. Geller, Mr. Sokacha, Dr. Jacobs, Dr. Harvard, Ms. Ishmael, Dr. Tembekwayo, Ms. Chirwa. I've received an apology from Mr. Van Staden. He's attending by elections in Pretoria, and Ms. Sukers is attending a mini plenary. Thank you, Chair.
That some of the members whose names were not called in but not present are likely to join us as we go along with the meeting. Let me then, honorable members, make this reminder that I welcome you all, those who have logged in into this virtual meeting of this committee. Before we proceed, I would like to remind you that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and apply in a sitting of the National Assembly. Members usually note that anything said in the virtual platform is deemed to have been said in the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noises which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video unless there are challenges in the area where you are with video. Members may make use of the icons on the bar at the bottom of their screens.
Honorable Chair, you're not audible.
Of or starting the next point, member may make use of the icons on the bar at the top of the which has an option that allows member to put up his or her hand to raise point of order. The secretary needs members refrain desist from unnecessary points of order or interjections. We shall now proceed with the business of the day. To end talking now and allow the business of the day to start. We are going to have the presentation by the public health specialists and registrars. This is the first part of today's sitting, and we will have subsequent ones that I will announce as we go along. May I get to know if the leaders of this institution are here, introduce themselves, and present. I must, however, apologize uphand for them that while they were aware we are meeting them, but the communication was not that strong, and therefore they sent their slide presentations to us a bit late, and we apologize upfront for that. Hence, you did not see those now. We already have presentations of the deans, the dental deans, and those of the human rights commission already in your emails, honorable members. Let me allow that leadership then to introduce themselves and start their presentation.
Thank you kindly, Chairperson, and good morning, honorable members. My name is Dr. Peters. I am a public health medicine specialist currently based in the Western Cape, working as medical manager at Groote Schuur Hospital, one of the tertiary academic centers here. I'm accompanied by Dr. Atiya Mosam. I'll give her an opportunity just to introduce herself as well.
Thank you, Chair, and thank you, Shrikant. Good morning, everyone. My name is Dr. Atiya Mosam. I am a public health medicine specialist. I am based at the University of Witwatersrand School of Public Health. I will apologize in advance. I may have to leave at 10 a.m. due to the last minute notification, as the Chair has indicated. Thank you. I'm going to hand over back to Shri.
Okay. Thank you very much, everyone. I'm going to share my screen with slides on it, and thank you very much for the opportunity. I just would like confirmation that you can see my slide set now.
Yes, we can.
Okay. Thank you very much, everyone. I will be referring to our submission, which was on the bill in 2019, and on the policy chapters which accompanied it. I will break down, you'll see at the introduction, I will just give you an overview of public health medicine as a specialty in South Africa, very briefly, and then I will be tied to our submissions in the official submission we sent to you. And basically what I'm going to do is I'm going to outline the roles of public health medicine specialists in the country, and where we feel they would be of best value to the system, which is being envisaged under NHI. Okay. So very briefly, this goes back to 1945, where we talked about universal health coverage at the Gluckman Commission of that year. And obviously we understand what happened after that. We failed to create a unified health system. And after 1994, we've been working very hard at primary healthcare re-engineering and making sure we have a system which provides equitable quality care for our citizens. And we know that we still have a long way to go, and we need to get to a state of universal health coverage. Now, during this time, over the last 50, 60 years, medical specialties have been developing in this country. And we belong to a specialist branch of medicine called public health medicine, which was founded in the 1970s. So just as you might see an obstetrician or gynecologist for pregnancy, or a neurosurgeon when requiring that particular form of surgery, public health medicine specialists are clinical doctors who have completed undergraduate training. They're fully qualified with MBCHBs. They've completed their clinical internships. They've worked 2 years now in state facilities and a community service here, generally at a smaller or more rural district facility. And then after that time, as opposed to 4 years in specialty training in medicine or surgery or those various subdivisions, we do 4 years of structured theoretical and practical postgraduate training in the actual governance and strategic support of public healthcare systems. So during this time, as registrars, we rotate in the departments of health, and we have intimate working knowledge of finance and supply chain, human resources, and the implementation of community health interventions, how to prevent disease and promote healthy lifestyles, which are integral to primary healthcare. So we've got expertise in planning, in monitoring and evaluation. We're very heavy on our data knowledge and statistical analysis. We should be at the forefront, therefore, for creation, collection, collation, and distribution of data to improve effectiveness, accessibility, and the quality of healthcare in the South African health system. We are spending money as government to train public health medicine registrars, but we don't necessarily derive the value we should be getting from this specific class of specialist. They have experience from grassroots level of healthcare service delivery to healthcare management, and many of us, like myself, occupy positions as healthcare managers in facilities, and we occupy these posts, clinical, hospital, district, and provincial positions. We are also present at the national level. Public health specialists who are in the public eye include Dr. Nicholas Crisp, Prof. Salim Abdul Karim, Dr. Wasila Jassat at the NICD. and as well as Dr. The name just skips Dr. Mark Blecher, who is a DG in the National Treasury. So we've got experience, and we are in the system, but we're not employed as public health medicine specialists. And that's what we want to map out today. So our training program includes health systems management, organization, strategy and design, informatics, how to use data, biostatistics and epidemiology, which is foundational to our discipline, looking at health economics and how we utilize funds in the public sector. We have a rigorous training in universal health coverage and the financial, the economic functions of a health system in improving outcomes and improving economic benefit of healthcare. We are specialists at health research and knowledge translation of health research into improvements in the healthcare service, as well as on top of all of those systemic expertises, we also are required to learn about non-communicable diseases, the diseases of lifestyle like diabetes and hypertension, infectious diseases, as you'll know, COVID-19 is front and center, but going back to HIV, AIDS, and STIs and all of the other infectious diseases, occupational health across all spectra, not just in healthcare services. Mining is a huge focus area up in Gauteng as well of ours, and then environmental health and climate change. So you can see we've got a very broad spectrum of postgraduate training on top of our undergraduate medical training on how to treat individuals. Now, the US CDC has a specific role for public health medicine specialists, and that is to monitor the health status and to identify and solve population level, community level health problems, to diagnose and investigate health problems and hazards in communities as opposed to those which might affect individuals, research new insights and innovative solutions to health problems, inform, educate, and empower people about health issues. We saw this in the recent waves of COVID, where as part of our College of Medicine South Africa function, the Council of Public Health Medicine was responsible for providing specific directives for COVID-19 related to everything from the taxi industry to schools and everything in between to government. We are responsible for mobilizing community partnerships and action. We, in our various, with the various other roles that we play in the provincial departments of health, we are at times the only doctors in the room who are then integrating responses between the Department of Health, Safety and Security, Hygiene, and engineers. We develop policies and plans on behalf of government, currently in an ad hoc fashion, but we'd love to do that in a more structured approach with the provinces and districts. We help with laws and regulations, and we also give input on legislation. We link people to needed personal health services and so assure availability of healthcare provision. On various pilot projects, we are using the unique patient identifier, which is being developed in various provinces, to proactively go out and seek patients who have fallen off the system and need to be linked to care, be that maternal and child health, be that geriatric care, be that psychiatric care. Using our knowledge of both health systems and individual health and data management, we put this to good use to try and integrate the health system to a greater effect. So 9 is assuring competency of public and personal healthcare workforce. Many of us do that as management, but there are others at district level who are public health specialists who are responsible for looking at our human resources on a district level and understanding our district health expenditure review on an annual basis. And so we are the strategists. Big thrusts is for district public health medicine specialists to be appointed to the district clinical specialist team. If you go through the handbook on the district clinical specialist teams, all the competencies required of people on those teams fall under what we are trained for during our 4 years of registrar time. And the role of specialists on those teams would be bi-directional translation between the district health management office and the district clinical specialist team in terms of pharmacies, finance, supply chain, and procurement information, being able to translate that into improved clinical service delivery in terms of volume, access, and quality of care, and being able to map that on burden of disease and healthcare outcome data. And lastly, there are some public health specialists working at central and regional hospitals, Some of them are managers, but there are plans in place to have public health specialists monitoring and evaluating these very large national assets and bridging that gap between clinical and corporate functions. So I'm going to get on to the specific submissions. I don't want to dwell too long, but basically you'll see many slides come up based on the draft bill and our submissions. And there are many suggestions, but they all fall down to basically 3 inclusions in the bill. The first one, the first suggested inclusion, deals with Section 5, the duties of the fund, page 14, clauses B, C, G, and H through R. So about the fund actively purchasing and procuring health services, medicines, goods, and related products, and healthcare services are advised by the relevant committee of the board, which will be funded by the fund on behalf of users. So these areas are all places where public health medicine specialists have expertise on procurement of the right healthcare services, informed by epidemiological analysis of geographic burden of disease. And so the suggested inclusion is the fund must, through coordination with health district PHM specialists, perform all of these functions. We understand that there's a central fund, but it's got to coordinate its work through the health districts, which have become far more prominent and are currently not capacitated to perform all the functions that they need to under NHI. And we feel that public health specialists at district level are a cost-effective approach to consolidating all of those activities, all those functions that need to happen at the district level, and then translating it into the clinical space. Okay. So clause G under the same section, take measures to ensure funding of healthcare services is appropriate and consistent. So we have insight into how the different levels of the healthcare system work, and we're a resource in advising how funds should be distributed, obviously in consultation with different members of the team. All of the clauses H to R, I won't go through each specific one, but just to say, those top 2 are collating utilization.
Hi, Councillor Billy.
You.
Hi, how are you?
For yourself.
Good, thanks. I'm so sorry we delayed you with the previous PPS assessment. I'm here with your political head, Lindy.
Who is speaking now? Continue, Dr. Shrikant. Thank you. Sorry, somebody forgot to mute as we had asked to mute.
Sorry about that. I got muted myself. Thank you. I'll continue. I just want to confirm how much time I have. I don't want to be too long. I'm going to continue, and I'm just going to be wary of time and leave enough space for discussion. Okay, so H through R, I just want to point out these clauses. So H, collating utilization data and implementing information management systems to assist in monitoring quality and standard of care. Now, we are starting to do this at a provincial level, and we're doing that through the public health intelligence units, which are based at provincial level. To enable this at district level, we would need a public health workforce at that district level. We have management, we have district directors and deputy directors, but they draw upon the expertise of public health medicine registrars currently who are in training, and the specialists who they work under. We don't have specialists for each and every district in the country, unfortunately, but they would be an asset and they should be mandated to utilize and analyze data coming from healthcare services and burden of disease, because they would be fundamental in pointing out to the NHI what healthcare services need to be purchased. It's a fundamental difference in having a public health specialist directing services rather than multiple clinical specialists of the different disciplines all advocating for their piece of the pie. There needs to be someone who is an arbiter, who understands clinical medicine, but also understands supply chain procurement and the fact that we need to prioritize budget. And those are people who are trained to master these activities during our registrar time. So under section 6 on the functions of the fund, to identify, develop, promote, and facilitate best practice. To clause 2, the payment of healthcare providers. Clause 3, facilitation of efficient delivery of quality services, submission of all required data to the fund, risk management, design of the health service benefits and goods provided by the fund, and obviously looking after healthcare referral networks in respect of users in consultation of the minister. So these clauses all cover content which PHM specialists are trained to master. So, you know, we're not just trained to, people say, you know, when you specialize in something, when you become a doctor, your role is to be safe as a doctor. When you specialize in something, you are the expert in your field, and that's what we are trained to do. And so it brings us back to that suggested inclusion. The fund must, through coordination with district public health medicine specialists, perform all of these functions. Section 22, clause 3A through J, responsibilities of the CEO. This is a suggestion, not a comment. So the CEO, as administrative head of the fund, is responsible for establishing all of these units. And we just advise that public health medicine specialists can be part of these units. I completely believe that public health specialists who are already at national and in the national units at NAPISA will be called upon to form part of the teams on these committees. But the skill sets are there to mandate that as well. But I have no doubt that we will play a role on these committees. The role of the District Health Management Office, this links back to that first inclusion. The District Health Management Office at times can be headed up by a public health medicine specialist, or it should definitely include public health medicine specialists as strategic advisors to the managers of that office, because in that role, we can support the District Health Management Office and connect it to the district clinical support teams. Okay, onto the contracting unit for primary healthcare. So these are the CUPs, which are going to play an expanded role in each district, but which currently do not exist. The contracting unit is comprised of district hospitals, clinics, and community health centers, as well as ward-based outreach teams, and the primary service providers organized in horizontal networks within a specified geographic sub-district area, and must assist the fund with all of these items. So all of this, and you'll see it starts with identify healthcare service need in terms of demographic and epidemiological profile of a particular sub-district. Now, to sit with tables of prevalence and incidence in geographic sub-district areas is the core function of the specialty. Epidemiological profile analysis of health districts is our function. So we should be mandated to perform this function in each health district, and thereafter assess referral system functionality, and then be able to inform the design of health service benefits for the district. So the suggested inclusion. So the first one was about district public health specialists. The second one is the contracting unit is comprised of a district hospital, CHCs, ward-based outreach teams, primary service providers organized in horizontal networks within a specified geographical district area, and with the support of the district public health medicine specialist, because we feel their role would be pivotal in this regard to assist the fund too. Okay, so those are the inclusions in the policy. In the NHI policy document, in chapter 6, entitled Reorganization of the Healthcare System and Services under the NHI, there is a specific line which notes the possible inclusion of public health medicine specialists in district clinical specialist teams. We advocate strongly that specialists should be included in order to provide the district health system clinical governance functions. And those are to monitor program health outcomes, assist in development, implementation, and facilitation of platforms for continuous professional development, develop policies, processes, and procedures to support referrals and other clinical protocols, as we did as registrars and as we were trained to do. Monitor the implementation and usage of the above policies within a district context. Evaluate health systems performance, specifically in terms of coverage, access, safety, and quality. At the level of the district is where we can merge data sets and understand what are the mortality rates of our facility. If you run a surgical service at a district hospital, what is the mortality rate per 1,000? What is the amount of money you're spending on the service? And those are public health specialist functions. Translating strategic goals, big picture thinking from province, to national, from national to province into the districts. You know, the problem we have with that implementation gap between policy and operation, we are supposed to be there to adapt those plans into job specifications, link those to appraisal mechanisms. And we're there to support clinical doctors in meeting, developing, and achieving professional targets and the key priority areas in the provincial annual performance plans play a role there. So based on those, the suggested inclusion, possible inclusion, we would advise district clinical specialist teams must include a district health medicine, a public health medicine specialist who will coordinate the work of the DCST with that of the corresponding district health management office and contracting unit in each health district. Okay, improving leadership and governance. There's new arrangements for purchasing of district health services via the contracting unit for PHC. So to separate purchasing from service provision, we identify a translation gap between the end user needs in facility and the efficiency requirements of the contracting unit, the information that they'll actually need to make purchasing decisions. And so that's also included in the fact that we are proposing public health medicine specialists be located in the district health management office, form part of the DH management team, as informed by the district clinical specialist teams. So play that translational role between management and the clinical service teams. Okay. The chapter on health promotion, and we're coming to the end here. Public health medicine supports overall public health functioning. We are obviously trained in clinical curative care, but we see our role in big picture population health thinking and promoting health and protecting communities from adverse health outcomes. And so we obviously welcome the inclusion of the National Planning Commission on Health Promotion. We also advocate for intersectoral collaboration to address the social determinants of health, and that's what we are trained to do. So we suggest that public health specialists, as part of their district clinical specialist team activities, be champions for health promotion. We are well suited to understand the natural history of priority clinical conditions. We're trained in treating HIV, but we're also trained in societal interventions to decrease transmission of HIV, be that circumcision, be it condomization and the ABC programs, or be it funding to prevent the phenomenon of blessers in communities. So we run the gamut of interventions from the clinical to the societal, and we're responsible for analyzing the effectiveness of these. So the levels we implement preventative and promotive strategies within patient care pathways and the different service delivery platforms, we should be playing those roles because we understand natural history of clinical conditions and public health interventions. Okay, roles, functions, management of governance of hospitals. Similar to the functions of public health specialists in the DCSTs, public health specialists in each hospital could likewise provide health systems performance monitoring and evaluation functions, bridging the translational gap between clinical and corporate function of health service delivery. And I know that in some large tertiary hospitals like Charlotte Maxeke, we have public health specialists in those roles. Enhancing the health workforce. While a number of strategies and systems have been put into place to increase the size of the workforce, we need interventions to improve performance of health workers through a total worker health approach. Public health specialists can be tasked with developing and implementing health workforce monitoring and evaluation frameworks through indicator development, looking at health workforce productivity and morale within health organizations. And we see how important that is, especially in the COVID pandemic, and how burnout has been amplified by the need to provide more care. And building the health service back from this global pandemic will be paramount. Information and research for monitoring of progress to UHC. Using various research methodologies applied to district health information systems data and operational activities, the progress towards universal health coverage can be scientifically described in order to facilitate routine decision-making where targets remain unmet. Public health specialists who are trained in epidemiological analysis and trained to use statistical analyses and statistical software would be able to use established tools such as the WHO Universal Health Coverage Monitoring and Evaluation Framework and adapt that to the South African context. Appendices which we've included in the submission and which I have on hand to talk to is our College of Public Health Medicine Guidelines, the clearing examination body of public health medicine specialists. They mandate what our competencies are. We've married these competencies to what is required in the NHI bill, and we have a table in Excel which we can show you, and the District Clinical Specialist Team's Handbook, which we refer to, which outlines a lot of the planning, coordination, monitoring and evaluation, and translation roles which district public health medicine specialists should play. So I will be wrapping up with these sentences from the South African Health Review of 2016. So it refers to public health medicine specialists. With their wide and versatile skills base, it allows them to work in district, provincial, and national units in technical and service roles. Their functions would include public health, population health need assessments, support for planning, implementation, service evaluation, and control of health threats. Public health units at national, provincial, and district levels should be established, and their design could build on the experience of existing units in the Western Cape and Gauteng. And we are looking at rolling out in further provinces, the Free State being the next, and Eastern Cape has also been engaged. Their staff would include multidisciplinary teams with public health professionals, including public health specialists and other PH professionals, and where possible, have strong relationships to academic institutions, just as our clinicians have and draw on their expertise from the universities. Public health specialists bring a university and academic expertise to government functioning. They are a potential resource providing public health intelligence to inform the process of health system development and restructuring as part of the creation of a system of national health insurance for South Africa. Just before I end, I'd like to just to give acknowledgement to the wide range of contributors, public health registrars and specialists across the country who gave input into this plan and whom we debated the inputs with quite substantially. Thank you very much for your time and for allowing us the opportunity to present to you today.
Are you Professor Peters?
No, not at all, just doctor.
But Peters is the name.
Yes, Dr. Peters.
You're so humble. I see you putting your name at the last. You don't put your name at the top of the contributors. Okay. Thank you very much. Honorable members, I have received so far, I've seen the hand of Honorable Sokacha. May we use this platform to give you numbers? So Honorable Sokacha is number 1. Can I just take the hands now? Please shout. Honorable Munyai, you can use the platform again now. You are number 2, Munyai. It's late now to write down. Just shout here. I'll take the names as you indicate. I've got 2 hands.
Jacobs, Chair.
Dr. Jacobs, you are number 3. Can we take all the names now? Okay, if none, I'm number 4. Okay. In that order, start Honorable Sokacha, followed by Honorable Munyai, Honorable Dr. Jacobs, and I'll be the last one. Thanks.
Thank you very much, Honorable Chairperson. Let me welcome the presentation by Dr. Peters. I was really impressed because he puts the clause and he puts the suggested inclusion as well, which is a very good thing. Doc, just one question from my side. I've seen that the doctor have always indicated that they are part of the system of the Department of Health. Now, I just want to know, why do they insist on explicit inclusion of the public health medicine specialists in various substructures, whilst they are an integral part of the health system? I just want to check, why are they consistently saying they want to be included in these structures. Thank you very much, Chair.
Chair, would you like me to answer each
Honorable
question?
Munyai. No, you've got
Okay,
all
I'll wait.
four, then you can come back right down. Honorable Munyai.
My question is why there's an area where he was opposed to some section of the act, but before I could do that, do you believe or do you support the principle of social solidarity? Or let me just also add the following question. If you say, for instance, both public and private funding that are proportional to the funding should go public, or let me just say, put it oppositely and say that, do you believe that the proportion of the funding should go public or should be tax funded? We should be able to get public tax in order to fund the NHI. That would be my question thus far.
Thank you, Dr. Peters. Sorry.
Okay, no, I was just confirming if that is what Honorable Munyai, whether he has completed. It does look like that. Go on, Dr. Jacobs.
Thank you, Dr. Peters, for a wonderful presentation. Very professional, and we appreciate you putting it forward as you did with your co-authors. I also want to just raise the question, why do you think there's a need for yourselves having to, at every of the clauses, emphasize the need for public health medical specialists to be part of any of the units? It does seem like it's you were mostly here to promote that, and we do understand that there is a role for every single specialist and medical doctor and other healthcare workers to be employed within the system and to participate in making meaningful difference to our country within the NHI. So I'd also want to know whether there are any other specific issues which you'd want to raise or comments you want to raise on the bill specifically. And whilst all of these comments are very, very helpful, because you've really packaged them very well, I'd also like to know whether you had made submissions to the NDOH, which will also then, of course, assist to take things forward. Thank you very much.
Okay, yes, Dr. Peters, when you started, you made reference to Dr. Klukman's report. I would like you to go back to that and maybe help me to understand its close relevance to a universal health in societies. And therefore maybe also see if maybe then that report was actually taken care of during those 50s, if maybe we would have had a different arrangement of the health service, of health systems in the country. You also are indicating that your training is exposing you to public health, maybe to say the current arrangement, the gaps that you see, are you able to assist to close them in the current situation, or maybe it would be a different health system that will allow you to effectively able to close those gaps? I see a latecomer. Honorable Gela, I shouted for names to be called in. Now I see your late hand. I'll take it nevertheless. Honorable Gela.
Thank you very much, Chairperson. Let me welcome the presentation, Chairperson. but also I want to ask the presenter that they support NHI, yes or not. But also the other question that I want to ask, it's about why do they insist on implicit inclusion of public health medicine specialists, inclusion in various structures, whilst they are an integral part of the health team. If the chairperson, that will be my question. Thank you very much.
Okay, this is a very popular question. Honorable Geller is amplifying what Honorable Dr. Jacobs was saying. Dr. Smith and your team, you can then assist us with the responses. Thanks.
Okay. Thank you, Chair, and thank you very much to the members for your questions. I hope to answer as comprehensively as possible. If you need clarity, please just let me know. Okay. And it might circle back to the same question, because I do see it was asked many times. And I was very conscientious looking at our submission, noting the fact that we were looking at multiple clauses and saying the same thing again and again. And I did have to reflect on that, knowing that I come from a discipline which has various specialties and subspecialties, and everyone who obviously sees a role for themselves in the system. The question as to why a specific inclusion of public health medicine, we are employed. There are 160 odd public health specialists in the country. We do not lack employment. We struggle to find people to fill posts that are needed in the country. So the problem is not one of us not having roles to fulfill. The problem is that the roles for us are not standardized in the country. So you will find public health medicine specialists doing fantastic work in various fields. Wasila Jasat at the National Institute for Communicable Diseases, of Dr. Nicholas Crisp's work on the NHI. You'll obviously know of Prof. Salim Abdul Karim's work on the MAC. Where we find there's a specific problem is the standardization of the function of public health medicine specialists to the value of the district health system and to the value of the system that's envisioned under NHI, where the districts are capacitated to fulfill the roles of planning, monitoring, and evaluation and epidemiological analysis. And so we feel that we would be pivotal in those roles. Currently, there is no mandate to have district public health specialists. And currently what happens, that means is that the urban centers and those that are closely linked to the universities in Joburg, Pretoria, and Cape Town have public health medicine specialists advising the chief directors of the different districts in health. And they do very good work. They understand their burden of disease, and they understand how cost effective or how cost ineffective they are. They give input into supply chain management for the district and for facilities, but they are not present in all health districts of the country. And the districts that require our help the most are the ones that don't have us in rural and smaller districts across the country. So we are doing fantastic work in a very small number of districts. And I would agree with thank you very much. We are an integral part of the system, but we are not standardized in our approach. And I would suggest that the work that we do should be standardized in specific roles under the NHI system of health, of district health services. The second point from Honorable Munyai, do you believe in social solidarity and public and private funding towards public healthcare? I think if you go through the medical specialties, we are generally ranked between biomedicine and social solidarity and equitable provision of healthcare. And obviously everyone has their range of opinions, but you'll find those in social medicine, preventative medicine, towards public funding of services and equitable distribution of healthcare. I don't think I would find any public health medicine specialist who would not be supportive of tax funding for the public health sector. That being said, as a doctor and a public health specialist, there's the cost argument that not enough money is spent on the public sector relative to the private sector. But we also have the intuition to know that the money we are spending on the public sector could be used more effectively and efficiently. It's not just a resource argument. And we know where we are lacking in quality, where just simple rearrangements in supply chain management, in finance, in pharmacy, in audit measures in facilities, in understanding our morbidity and mortality could improve the system at current levels of financing. But obviously we would support more financing through taxation. So Honorable Jacobs also talked about why the specific need, and I think specifically also mentioned, why is it that we've mentioned ourselves throughout the document in various clauses? The difficulty is we do fulfill a lot of functions, from health systems management, service and design, to epidemiological analysis and burden of disease studies, to actual top-down management and strategic advice to managers, in addition to economic evaluations of healthcare services. So you see us appearing very many times, and I understand it seems odd that we would put ourselves forward in such a prominent role at many different parts in the document, but it really boils down to that pivotal role. And I think it's really the fact that we've been mentioned so many times in our submission is actually a function of the what is being required of the health district as a unit of the health system. So from district health systems, from the WHO and going back many decades, being advised as these units of the healthcare system, they need to be able to procure, they need to be able to analyze their burden of disease. They need to know at their local district level, what is the quality of care provided in their facilities? And if there is deficiencies in that quality of care, how to improve them. So there is a lot expected of a health district in the district health system model. And looking at the NHI documentation, that's definitely where they want to go. A fund who is going to be paying money to health districts needs to know that that district is functional in all of the items necessary to run a health service. And because we have that multifunctionality, which has been employed at national level and provincial level, I would argue that the district requires a public health specialist to capacitate itself to perform all those functions. Dr. Dlomo, sorry, and you did talk about the need to submit to NDOH. We had submitted to NDOH prior to the initial submissions in 2018, but I agree with you, it's very important to engage with them as well. The National Department of Health, we are busy engaging with as a training site for registrars as it is, and obviously it would be extremely important for us to engage them further. Dr. Dlomo, the Dr. Gluckman report of 1945, and you referred to, whether those recommendations had been followed, would we be sitting in a different world right now? So at our annual conferences in public health, we have the Gluckman speech. And so we hearken back to days of planning past, where health administrators in the system, we didn't have public health specialists at the time. They were known as the previous medical officers of health. They longed for a system which would provide public health care, but also look at the wider system of social determinants of health. We are, realistically speaking, going into a very difficult period in the country's history, as well as globally, with the pandemic, as well as our financial situation at home. Yes, we do need to provide good quality of care, but we need to provide good value of service for money. The money that we spend on healthcare should be done appropriately, but we can't allow the second point to happen from the Gluckman report. Hospitals should not be costly monuments to the failure of preventative services. And I think that's very poignant, and it was in the 1940s and it is now. Preventative services means everything from making sure our education system is working and making sure we have safe communities and policing, security, hygiene. It can't just be that we look at only healthcare. And so public health specialists play that role at the district level. And it's important at the district level because we need to integrate with all of the other service providers and local government structures to truly influence and impact the health of people. We can't just cure people, we need to prevent disease. And so, yes, if that had been implemented, Dr. Dlomo, but we're then dwelling in a world where apartheid never happened. Unfortunately, at that election when apartheid as a system was put into place, the structures of community health centers, of the focus on nutrition, housing, health education, and of caring for people in communities and understanding local area burden of disease, that went out the window to capacitate a dual system of tertiary academic excellence for a very small section of the population and underfunded primary care and also traditional homeland structures for most of the population. We wouldn't be in this situation where we are now. So tying that all together, and Honorable Geller, you did ask, why is it that public health specialists should be integral members of these districts? It really ties it into that vision of saying we want a system which has a central fund which procures and purchases services from capacitated district health systems. And there's about 52 or 53 in the country. It really boils down to having a capacitated health district. And capacitated health districts need strategic advisors. They need people who understand clinical service delivery and can marry that to supply chain management and finance, and to be able to ensure the fund that they are dealing with well-capacitated districts, that they can be sure are able to provide quality services, that are able to audit themselves, that are able to integrate the way they function with other local government structures, and that they have managers who are employing people who can advise them on strategy and management of their services. So yes, there are many roles that public health specialists play. I argue that we would get more bang for our buck if we have one public health specialist in each health district with all of those defined roles and activities they need to play and value they need to give to the system. And so that is the thrust of the argument of the submissions, is to really capacitate those district healths, those health districts. We would need a public health medicine specialist in each one to fulfill those roles. And that would be bi-directional between management and strategy and supply chain and finance and information management and the district clinical specialist teams who are responsible for healthcare service delivery and prevention of ill health in communities. Thank you very much.
There are two members who have requested to make follow-up questions in this order. One is Honorable Munyai and the second one is Honorable Geller. Can I have those members please raise their questions?
Thank you very much, Honorable Chairperson, and thank you very much, the Honorable good doctor. What I want to understand critically clear, crystal clear, can the doctor please explain if he supports the NHI? This question has been raised before, and the reasons for that support. Does he support a single payer, single fund based on the principle of equity and social solidarity? Because I raised those issues, I think the context could not be understood.
Okay. Honorable Geller. Honorable Munyai, have you finished?
Done, Honorable Chair.
Okay. Honorable
I hope
Geller.
the doctor understood my question.
Yeah. Yes, thanks. Honorable Geller, come through. Okay, Dr. Peters, you can answer so long. There seems to be a problem with Honorable Geller.
Okay, thank you very much. Thank you very much, Honorable Munyai. I can say unequivocally that I support NHI's model of a single payer and single fund. And my rationale for that is I understand strategic purchasing. The whole aim of NHI being a single purchaser of healthcare services in the country means that they would dictate the price that they are willing to pay for healthcare. And I know that is pushed back against by many people in the medical disciplines. But we know intuitively that good healthcare is not expensive. It's not necessary for healthcare to be expensive. And so there's this inflation in cost in the private sector. And I would say it's built on this assumption that there's poor quality healthcare in the public sector, which is not true. So yes, I definitely support the single payer, the single fund, for the reason that it enables strategic purchasing. Coupled with strategic purchasing, you need to purchase services from a health district that is well capacitated. And so that's that fundamental underlying thrust of the argument. You need the single purchaser to push down costs. You can't have people just saying, I want 300% of medical rates for my services. But you need a capacitated district health service that can deliver on what the fund will be purchasing from them. So yes, I definitely support and agree with a single payer, single fund model for the NHI.
Honorable Keller, are you able to come through now? Okay. Honorable Keller, it does look, oh yes, come through, Honorable Keller.
Chairperson, I don't know actually, but I think, Chairperson, the question I wanted to ask, it's about whether they are supporting or not fully are supporting NHI bill, but also as we know that apartheid left us with a legacy of apartheid, and NHI is a means to reduce the growing inequality in access to quality of health care. Are you agreeing or not with this assertion? That was my question. But also I heard that he was also touching the issue of covering the issue of single payment, Chairperson. I will pause the Chairperson because of my connectivity. It's a challenge this side.
Yeah, okay, the issue of a single payer, he actually has spoken to it, single purchaser. Maybe you can then go into explaining further the issue of apartheid medicine.
Okay, I can answer? Okay. Thank you very much, Honorable Geller. Thank you, Chair. Yes, just to reiterate, we support the NHI bill and we support the single payer and single fund as a strategic purchaser. The mention of apartheid legacy, and I think it definitely ties into this dichotomy. The apartheid legacy was to have two separate systems, or really a system and just whatever anyone else could get their hands on. And so there was this move towards tertiary academic palaces that provided, excellent healthcare and a second-rate system for everyone else. But also with that, this drive towards centralizing control of the system and centralizing expertise at a national level or even within these large tertiary hospitals. And an aim of the new country, the new government after 1994 with PHC re-engineering and moving towards a primary healthcare approach on which universal health coverage will be built moving forward, was to increase access and increase quality of care to the millions of members of our population so that everyone has the right to health as contained in the Constitution. Now, that apartheid legacy went hand in hand with centralized control and management. under the new system, I know that we devolved a lot of power to the provinces. Under the NHI, even more power will be devolved to the district level. And so it goes hand in hand with increasing access to quality coordinated care. We did it for the provinces. We're now moving on to increasing access to quality care in each and every district of the country. And for that reason, we need decentralized strategic management of health districts. And so that is what public health medicine specialists would do. They would be strategic advisors at the health district level. They would understand finance and supply chain flows. They would understand healthcare outcomes. They would be fundamental in understanding the quality of healthcare delivery and the quality of health, the quality of lives that people were leading in health districts. And they would be fundamental for the fund to use to understand how each health district is doing. Thank you.
Okay, thank you very much, honorable member. If I was younger, I would have chosen your speciality. Now I'm too old to let, but I will use you to learn a lot from what you are telling me. It's a very good listening to a good lecture. Thank you very much for opening our space in that field that was not clear to some of us, and in your contribution towards the NHI process. Honorable members, we are going to take a short break. It was in the next 15 minutes. We are going to be listening to, hope it's not going to be Dr. Peters again. We are listening to the Public Health Association. Let me just check that. Yes. What are we going to get at 15 minutes in time, Ms. Machalamba? Ms. Machalamba is not close by, but it's
Sorry, Chair.
Yes.
I've asked them to join at 10 past, but we can start at 15:15. It's Public Health Association of South Africa, Chair.
Public Health Association of South Africa. Honorable members, grab your cup of coffee, come back. We ask them to start at 10:10, and they are available to start with us at that time. Just grab your cup of coffee, tea, nothing stronger than that, and come back to the meeting. Thanks. Okay, honorable members, I am informed by our secretary that the Public Health Association of South Africa has joined us and they are willing to take us through their presentation. Welcome, leadership. You are interacting with the Portfolio Committee of Health, and they will therefore want to give you this space, firstly, to introduce yourselves, and then whoever is going to lead the presentation to do so. We will appreciate as you introduce yourself to show your video and then move on in that way. Thank you very much.
Okay. Good morning, Honorable Chair, Honorable Members of Parliament, and Honorable colleagues. My name is Harsha Samaru. I'm the current president of the Public Health Association of South Africa, and I'm joined today by Dr. Owen Friedman. He's a very senior member of our organization. He's actually been a member since the organization's inception in the year 2000, and I'm quite grateful to have him with us today to share the submission of our organization with you. So
you can continue. You can continue, ma'am. Thanks.
Thank you, Chair. So just to give you a bit of background of our organization, the Public Health Association of South Africa is a registered Section 21 not-for-profit organization. We are referred to by the acronym PASA, and we represent the broad public health community in South Africa. Our membership includes a diverse range of public health practitioners, including doctors, nurses, allied healthcare professionals, academics, researchers, as well as civil society activists. So our vision is to provide leadership and a collective voice to improve health. And we want to do this via knowledge sharing, capacity building, partnerships, and advocacy. And we are committed to promoting health and health equity. And thus we are very keen to be involved and engaged with the discussions and deliberations as the country moves towards a national health insurance system. So Dr. Friedman and I will be doing the presentation together. I will do the first half and he will do the second half. And we've chosen to refer directly to our submission today. And the reason we want to do this is we feel that this is the best way to make the information most accessible to the members of the committee. And we feel that this is important because we feel that you will find that a lot of the points raised are distinct and also very relevant to your deliberations. So I do hope that you have a copy at hand. This slide just gives an overview or a roadmap to the submission as we will discuss it. So with that, I'm going to go directly to the submission. And at the outset, I think it's very important for us to state that we welcome the release of the National Health Insurance Bill. And we thank the National Department of Health as well as the Parliamentary Portfolio Committee on Health for the opportunity to comment on it. We are also committed to working alongside the department in advocating for, formulating, and implementing health systems reforms in line with the principles of quality healthcare and universal health coverage. As a collective, we recognize that the inequalities and injustices that pervade the South African society, especially and including the inequalities related to access and quality of healthcare in the country, are directly related to the country's apartheid history. However, we also recognize that these injustices and inequalities have been intractable during the 26 years of democracy. We also note that the inequalities in health and access to healthcare are in large part a result of the fragmented health system in South Africa. What I mean by this is the overburdened and under-resourced public sector, as well as the inefficient and largely unregulated private sector. And this misdistribution of resources between the two sectors constitutes a catastrophic injustice that risks destabilizing the foundations of our South African society. So we believe that equity in health cannot be achieved without equitable distribution of both health and related resources, without reducing the burden of paying for healthcare by members of the population. We value the goal of ensuring financial protection from the costs of healthcare and recognize that cross-subsidization requires the pooling of revenue to facilitate active and strategic purchasing of healthcare services based on the principles of universality and social solidarity. And I think it's very important for us to stress upfront that we support the principles of universal healthcare and the intentions of the department's move towards a national health insurance. We must simultaneously share concerns about certain aspects of the proposed bill because we fear that these aspects, as it currently stands, risks further ingraining the very inefficiencies and inequalities that it seeks to counter. So we do hope that this feedback— Yes?
Dr. Somaru, are you reading from somewhere?
From our submission, not directly, but I'm referring to our submission.
Okay, that's fine. The full document, the submission.
Yes, I hope you have a copy. We can share it.
Yeah, we thought you were going to take us through your presentation in whatever you kind of extracted from your presentation in the slide format. I don't know whether that's what you have or you don't have that. You don't have it.
Well, we actually prefer to refer directly to the document because we felt that the facts were clearly stated.
Okay, all right. Go on then.
Okay, thank you. Okay, so essentially what we're going to do is look at the actual document. Firstly, looking at the comments and suggestions of the different chapters of the bill. And then we've also added other comments that we've filed might be useful to engage with. So we hope that this feedback will contribute meaningfully to the discussions and the deliberations. And yeah, at the end of this, like I said before, I will do the first half and Dr. Friedman will continue after me, and then we'll be available for comments and discussion as well. So starting off with chapter 1 and the purpose and the application of the Act, I think we know that the aim of the Act is to establish a national health insurance fund in order to fund the provisions of universal health care through the bill. However, the bill also introduces organizational and structural changes to support functioning of a single payer and funding system. So given the varying degrees of uncertainty regarding the feasibility of certain of the proposed structures and structural changes in the bill, we think that it might be worthwhile that this be given more consideration before being legislated in the bill. So we believe that the Act establishing the fund should be written in a way that does not hinder future legislative processes, especially for issues that are not inherently related to financing. And we suggest that sections of the current bill that touch on arrangements not directly related to the actual fund should be either removed or maybe the level of detail around these arrangements could be reduced to allow more time to consider the most effective proposals. And this will allow for learning from experiences and also to select the most efficient and appropriate models going forward. Okay, so I'm going to move on to comments from chapter 2. And chapter 2 in the bill relates to access to healthcare services. And so it's recognized that the bill is aligned with provisions set out in the Constitution, as well as the National Health Act, the Refugee Act, and the Immigration Act, as it relates to refugee rights to access healthcare services in South Africa. There are some concerns, however, around the lack of full population coverage and the restricted access to healthcare services for asylum seekers and illegal foreigners. I think the one thing is that there are human rights considerations, and then it's also important to consider that this could have potential impact on communicable diseases that are not notifiable, like HIV. There could also be potential impact from non-communicable diseases, because if we only provide for emergency care as opposed to early preventative care, we are going to be treating patients when they are more sick. And also, as a healthcare system, we are going to be paying a higher cost for this treatment as opposed to early treatment, preventative treatment early on. Okay, and so relatedly, we feel that in Section 5 of Chapter 2, attention should be paid to registration of users so that restricted access to users who do not have the required documentation that's stipulated in the bill are not prevented from accessing healthcare services. Okay, so now I'm going to move on to comments from Chapter 3. And here it says that the bill establishes the fund as a Schedule 3A autonomous public health entity. However, the powers of the Minister of Health are heavily concentrated throughout the structure of the fund. And we feel that this might present a potential conflict of interest. I think the bill provides for significant centralization of decision-making power with the minister, including for very technical issues that raise the question of accountability and transparency. And so our suggestion is that the fund should ultimately be accountable to Parliament. Okay, so now moving on to Chapter 4, in terms of our submission, and I'm referring to the comments there. And here, sections 13, 1, 3, 8, and 9 grant extreme power and authority for appointment and removal of board members to the Minister of Health. There's no mechanism in place to ensure that the minister is not vulnerable to outside and political influences that might lead to inappropriate appointments. And so here as well, we feel that this section could be reconsidered. International evidence has clearly demonstrated the importance of clear separation of political and administrative powers across all levels of the health system. And so here we feel that the minister's powers should be reduced or counterbalanced by another authority, such as Parliament. Okay, moving on to Chapter 5, and similarly here, Section 19.1 indicates that a transparent and competitive process will be undertaken to appoint the CEO. However, the next section, 19.2, indicates that the board, which was appointed by the minister, will conduct interviews and that the minister will approve the recommendations of the board. So here again, we feel that this presents a potential conflict of interest with the minister having excessive influence, and this might undermine the autonomy of the CEO. And our suggestion here is that this appointment be confirmed at a higher level, potentially by Parliament or the presidency. Moving on to comments from Chapter 7, this relates to the advisory committees established by the minister. And there are 3 advisory committees listed: the Benefits Advisory Committee, the Healthcare Pricing Committee, and the Stakeholder Advisory Committee. And all these committees have vital and inherent implications for implementation of the fund, as well as provision of universal healthcare in the country. So there's also a clear need for transparency around the creation and the constitution of these committees. And currently, all these committees are defined as advisory. And so this suggests that they might not actually have the power to make decisions. And the power again lies with the minister, who, according to the bill, must have a representative on each of the committees. And so here we feel that there needs to be clear definitions of the powers, roles, and capacities of all committees, especially in relation to the board and the minister. Okay. So now moving on to comments in Chapter 8, and Chapter 8 of the bill relates to general provisions applicable to operations of the fund. And similarly, like in Chapters 3, 4, 5, and 7, in Chapter 8, Section 31.1, it's outlined that the role of the minister is being responsible for governance and stewardship of the national health system, as well as governance and stewardship of the fund. And so here we believe that this presents the similar conflict of interest raised previously in relation to excessive power and responsibilities that might be placed on the minister. And we suggest that the duty of governance and stewardship of the fund rather be assigned to the CEO of the fund. So Section 33 states that once the NHI is fully implemented, medical schemes may offer complementary services that are not reimbursable by the fund. And we believe that this might make sense in time when the health system is in a position to fully deliver universal health care and when there is a diminished role for medical schemes. However, during the transition period, from now through the transition system and finally to the point where we have optimal coverage of healthcare services under a fully NHI funded system, patients might encounter aspects of suboptimal quality of care if this is actually implemented. For example, there might be unduly long waiting times because the services are not yet mature enough to cater for the demand. And so we feel that it might be safer to allow patients as well as medical schemes the option of paying for help that might be needed in the interim. And we suggest that there not be a restriction on the services that medical aids are allowed to fund. And relatedly, we think that attention needs to be paid to the quality of services from providers that have not been accredited by the Office of Health Standards Compliance or the National Health Insurance Fund. We feel that it might be beneficial if considerations include the need for certification and or monitoring of establishments and practitioners to be able to provide healthcare services irrespective of whether they contract with the fund or not, and related support for the achievement of this. And we think it might be beneficial in this to actually have incentives for contracting with the NHI fund. So moving on to Section 37 of the bill, and this relates to the establishment of contracting units for primary health care provision. And these are referred to as CUPs. So the CUP comprises of a district hospital, a clinic, a community health center, a ward-based outreach team, and private providers. And the role includes identifying accredited public and private healthcare providers and managing contracts entered into with accredited health service providers. So this new structure seems to be the equivalent of the current sub-district units with prescribed levels of care as well as enhanced health financing competencies. And while the CUPs sound theoretically comprehensive, the concern is that introducing a new operational model into the health system nationally as part of the Act without prior proof of concept or contextual feasibility might not be the best way to proceed. Especially of concern is the current situation. There's varied availability of the prescribed levels of care within different sub-districts in the country, and especially there's decreased availability in rural areas. The private healthcare sector also functions without consideration to interdependence with the public healthcare sector. And it would be important that these mechanisms and manners of interaction between the private sector as well as the public sector be clearly defined so that they function well within and contribute to a clear service delivery platform within an NHI funded system. Okay, and so what we suggest here is that the introduction of the CUPs into the district health system actually be reconsidered at this point in time. If it is, however, felt that this organization of the system is the best model to adopt, the structures, capabilities, and capacities of the existing district health system should be considered in relation to the envisaged model. And we further suggest that the required changes need to be planned for with appropriate consideration given to the required structural investment, capacity development, and incremental and realistic timelines for the introduction of sequential changes. And this also, it's in accordance with the constitution of the country, which allows for the progressive realization of healthcare within the current resources available. Okay, another point that was noted, that the proposed role of the provincial departments of health is not apparent in the bill. And currently the National Health Act places the responsibilities for implementation of national health policy at the provincial level, though the bill might suggest that these functions be moved to the district and sub-district level. Section 20 of the bill indicates that liaising with district health management officers would be the responsibility of the CEO of the National Health Insurance Fund. If this is the case, it will require significant structural and functional changes to the current health system. And it disregards what is already established by the provincial health management system. And the suggestion here would be that the structures, capabilities, and capacities of the existing provincial health system be considered, and that any proposed changes be planned for in accordance with consideration to, again, structural investment, capacity development, especially at the lower levels, and an incremental and realistic timelines for introduction of the sequential changes. Okay. So overall, it seems that there might be lack of clarity surrounding the envisaged service delivery platform, and we feel that it's important to be addressed, maybe not directly via the bill, but perhaps through simultaneous planning and legislative processes ahead of us deciding how to fund the services. Okay, so also for optimal purchasing within a single payer NHI funded system, the entire health system needs to be considered. And this includes the public healthcare facilities, patient transport, referral systems, private healthcare facilities, and non-governmental organizations. And I think the private healthcare facilities and non-governmental organizations are especially relevant given the marked potential for incorporation and coordination with these sectors. This might assist to address many of the current gaps that exist within the public health system, as well as provide for an inclusive service delivery platform that will be better able to support the goals of universal health care and health equity. And I think one thing that everyone is aware of is the current status of the South African healthcare system. I think at the moment, the Office of Health Standards Compliance does conduct audits on our healthcare facilities. And when the submission was done, it was concerning that approximately only 1% of the 696 public health establishments that were assessed were able to meet the standards for accreditation. This has changed, I think, in the more recent report for the year ending 2018-19. This had improved to 19% of 730 facilities that were addressed. However, it still falls short of what is required. And the consequent concern is that the accreditation process will render majority of the public sector facilities ineligible to be contracted by the NHI fund. And this will result in a heavily private sector dependent delivery model. So here, requiring accreditation by the OHSC, which is important, introduces the risk of creating an open market for the private sector. And it's a very real concern that if very few public facilities achieve accreditation, the NHI would result in a de facto privatization of our South African healthcare system. And so the implication of this is that we need to consider the regulatory mechanisms and also the current circumstances among the public and private providers especially as it relates to providing contracts and contracting. Relatedly, the bill should provide clarity on what should happen to public health facilities that do not achieve accreditation and what measures should be put in place to strengthen the public health capacity to meet the accreditation standards. And here as well, this relates to the incremental realization of our healthcare goals. So at this point, I'm going to hand over to Dr. Owen Friedman, and he's going to take us through the second half of our submission.
Good morning, everyone. Honorable members, Honorable Chair, Dr. Dlomo, thank you for the opportunity of giving us this opportunity to present our views. I'd like to just start off by introducing myself briefly. I'm a public health physician, and I've been an activist in the health system for many decades, advocating for a transformed health system informed by the primary healthcare approach and epitomized in our National Health Act. And it's a great privilege to be part of a public health team, and you heard about our experience early on in the presentation today, to add our discipline's insight into the establishment of the NHI, which is something which we as public health physicians have been advocating for all of our professional careers. I think it's important to note, because the question has arisen several times, do we support the NHI? And the answer is yes, we strongly support the introduction of the NHI, which we see as a form of universal healthcare provision. In other words, that everybody, no matter who you are, would have equitable and quality access to healthcare. So we're strongly in support of the principle. In fact, this principle has been adopted by many countries throughout the world, and it is inevitable that most countries, if not all countries, will move to adopting this at some time in the near future. So it's very fortunate that South Africa is moving in this direction. However, there are pitfalls. There are severe pitfalls, and many countries that have been through the process of moving towards this have had huge dislocations in the healthcare system. And this is why we make the comments that we do. I'm going to try and share my screen, if I may, because I'm hoping that you can see some of the things that we weren't able to show earlier on. And I'm just hoping that I can do this effectively. And please let me know if it's working. Can everybody see this screen?
Yes.
Okay.
Yes, we can see. Yes, we can see.
Okay. So what I've done is Dr. Samaru has basically been going through the document that I have here. This is just my version. It's an annotated document, the same document that you have in your in the submission that we've made to you. And what I've done is I've gone through it and made some notes for myself, which I will draw to your attention because I think these might be useful things for the committee to think about. I'm starting on chapter 10, which is where Dr. Samaru left off. And this is really the crux of the NHI, because the NHI is, as we've heard, a single system, single payer system. And before I go through this, I'd like to just tell a story, because a lot of the time these kind of legislative language is quite abstract and often makes it difficult to understand what this means for the ordinary citizen. So I'm imagining the story of a lady called Miss Dlamini, who is a 35-year-old woman with 2 children and a breadwinner, who is very grateful to have recently had a job. And she's now working in an industrial company as a cleaner, earning more than the minimum wage. and in quite a progressive company who, in addition to giving her, to contributing to a medical aid for her, is also arranging for a general practitioner to visit the factory once a week to make sure that anybody that has a health concern is seen and referred if they need to. And what happens is that this has been working quite well for 5 years or so until the National Health Insurance Scheme is introduced. Now, as we know, with the National Health Insurance Scheme, she will now, which she is obviously very enthusiastic about, she is able to go to her nearest provider and obtain primary care. So she, in line of what the provider that has been selected is a local clinic which she goes to. Now, as it happens, she has a pneumonia, which obviously neither she nor the clinic know about. She's examined by very competent nurses, not necessarily a doctor, because not all clinics have a doctor. And they do their best, but they don't, they feel that the condition is more serious, so they refer her to the nearest hospital, which is a public hospital, which is the preferred provider. And it's a very busy hospital, very overstretched. Since the advent of the National Health Insurance, many more patients are making use of the facility. And unfortunately, it takes a long time for her to be seen. The doctors that see her are busy, and they miss the pneumonia, and she's sent home where she dies. And her family are very aggrieved by this death because they are told that this was a preventable death, an ordinary lobar pneumonia, which could have been prevented by the simple administration of penicillin if it had been picked up. Now, I'm going to use this story to illustrate a few of the issues as we go through the rest of the document and illustrate why it is very important that as we introduce the National Health Insurance, which we surely must, there are pitfalls on the way which we must avoid. And as legislators, obviously, it's your duty to make sure that these things are taken into account in ratifying this legislation. The first thing that is of urgent interest in the legislation is the fact that we are seeing that the litigation bill is spiraling out of control in South Africa as it is. Now, what we have here is a single payer fund, the NHI fund, which for the legal profession is going to look like the road traffic accident fund looked to many of the legal profession before. In other words, if there's a death and it potentially could have been prevented, it will be subject to huge litigation. And as we see, 24 billion in the years 2010 to 2014, the litigation bill was 24 billion, which is a very substantial part of the budget. And it appears from all the evidence that we have that this amount is escalating. So the first point that we wish to make is that it is very important that if we have a large fund of money like we are in a pool such as the NHI fund, that there is a piece of legislation which, in other words, that the bill should include a no-fault compensation process, which would mean that it would limit the amounts of money that could be claimed on behalf of somebody that suffers a problem for whom there has been negligence. Why this is important is if this is not done, then the proportion of the amount of money that we have available in our budget could become much diminished. In fact, it could be a very significant reduction. And we have, in fact, the example of the Road Accident Fund, which in fact now has got a no-fault payment compensation, and we are suggesting that there's a simple and method of doing this for our fund as well, for the NHI. There are many other aspects on which the bill is silent, and this is of concern because some of these areas are going to be very important. we think that it would be best that we see the introduction of NHI as a process which will take some time, which will give us the opportunity to learn in small steps from the mistakes we will inevitably make. In the business sector, particularly in the IT industry, it is very seldom that a huge new project will be implemented all in one go. The idea would be to introduce it incrementally, test the components, and as they begin to work and you gain confidence in the system, you introduce more components. In other words, it's what's called an agile approach or an incremental approach. And we believe that the legislative process, in the same kind of way, should be spread over time so that it gives us time to learn how to do this well. And obviously, there needs to be funding for this, and there needs to be several processes. The bill already suggests that there will be a phased approach, and we would encourage this phased approach and say it should possibly be even more phased. Now, turning to some other more general comments about the bill. As I've said, we support this, but it heavily uses health insurance language, commercial and health insurance language. Now, we feel that given that we are talking about public sector financing and public sector developmental goals, that we should start to introduce more compassionate language, which is not all health insurance and money orientated. For example, the word universal healthcare, which is the general term that's used throughout the world for national health insurance, is a compassionate way of talking about something which is different from the market-oriented neoliberal approach. And we think it's more progressive. So we feel that the bill needs to locate itself within the more progressive general development finance discussions that are globally. For example, the Addis Ababa Action Agenda of 2015 itself was located within the Monterey Financial, the Monterey Consensus for Financing Development from 2002, and the Doha Declaration or the TRIPS Agreement. In other words, there has throughout the world been a progressive movement in the direction of universal health care, and we need to use that kind of language rather than market-orientated language in the way that we frame our legislation. Our submission provides quite a lot of information on these concepts, and I think it's important to take this into account. Now, the other thing that we are concerned about, as I said at the beginning, our National Health Act was developed within the framework of the primary healthcare approach. In other words, we recognized that the primary healthcare approach as an approach which was emphasizing the importance of health development, the importance of community participation, the concept of equity, the idea of accessibility, all the ideas that basically do inform the bill. These are all informed by the concept of primary health care, and yet the definition of primary care in the bill is a very restricted one compared to the one in the National Health Act. And we feel that this has the potential to limit the way that primary health care is understood, particularly the developmental and participatory aspects of primary health care, which are there to emancipate people, which are there to ensure that we do not forget the developmental goals of the state, including the provision of what is called the social determinants of health, things like water, nutrition, education, employment, housing, transport, etc. These are all things that people need. And you cannot be healthy if you do not have adequate nutrition, you don't have adequate water supplies. Now, the primary healthcare approach has this as a central concern. And as I said, at the moment, the definitions fit more the concept of primary care rather than primary health care. Now, why that is important is that if we do not have a definition of primary health care, we could begin to lose focus on the most important part of the healthcare system, which is to, one, prevent illness, but two, to create a healthy population through creating the conditions which are healthy. And if we do not focus on health protection, health promotion, we could wind up with a very expensive healthcare system focused very much on remunerating illness rather than promoting health. So the next point in our submission is that we need to avoid over-medicalization. Now, what that basically means is that instead of concentrating so much on the payment for services, particularly clinical services, we should be giving emphasis on creating conditions in society which are health improving. And this doesn't happen within clinics and facilities. It happens through health promotion programs and through general development programs focused at meeting basic needs, such as I said before, health, housing, water and sanitation, and a clean environment. And of course, public health measures such as immunization to try and prevent preventable diseases. And of course, as we've seen during COVID, this is of major importance if we are to have a healthy economy. So we feel that the bill would be greatly enhanced if there was a better mechanism for the financing of the non-personal health services, in other words, the non-clinical services, which is why I think we heard the submission this morning about the importance of public health specialists who are non-clinicians, who see the general picture that we cannot have a healthy society if the factors in society such as inadequate nutrition, inadequate work opportunities, inadequate housing are still there.
Dr. Friedman, you have
Yes.
you have 5 minutes to complete your presentation.
Okay, right. I'm going to just say that we have emphasized the critical importance of health promotion, and we've acknowledged the importance of the social and economic and environmental determinants of health. And we've advocated that we need to see this as a key aspect. So in other words, we're calling for health to be to work intersectionally with other departments and to take a whole society approach, and not necessarily to base everything on a medical model of disease, but as part of the whole population perspective. And I think my colleagues earlier on have talked about the importance of public health surveillance. If we're going to be effective, we need adequate surveillance. We need to fund occupational health services, which again fall outside the ambit of clinical healthcare. And we need to strengthen the participatory approach to improve our institutions. We need to be aware of the importance of the use of innovative technology, particularly digital technology. And in conclusion, we would like to see the bill much more closely articulated with the National Health Act, which we see as a very progressive document and a very progressive framework. And we are excited about the potential for implementation of the NHI, but with the caution that it needs to be done incrementally. We need to build on success. We need to make sure that our public health sector is adequately accredited so it can compete with the private health sector and be effective in that process. And with that, Chair, I'll hand back to yourself.
Okay, thank you very much for that. You just finished all your time. I hope when you respond, you'll be able to assist us to keep to the time because there's other presenters later in the day. The following members have indicated their desire to engage with the presentation. Honorable Sokacha, you are number 1. Honorable Munai, you are number 2. Honorable Kela, you are number 3. Before I close, may I get now if there are any other members who would like to ask?
Jacobs, Chair.
Honorable Jacobs, Dr. Jacobs, you are number 4. Any other? Then the chair is going to be number 5. Let's start in that order, honorable members, starting with Honorable Sokacha.
Thank you very much, Honorable Chairperson. Let me take this opportunity and thank the presentation. Chairperson has a few questions. The first question is that the presenter talked about sections that must be removed from the bill. I just want to check which section specifically and explicitly does the Public Health Association of South Africa want to be removed from the bill? That is the first question. The second question, Chair, is how do the Public Health Association of South Africa expect a CEO to exercise oversight over himself or herself if they are expected to provide governance over the fund? And then the third question, Chair, I just want to check from the Public Health Association of South Africa whether they support the bill. Thank you very much.
Honorable Chair, may I proceed? If I may proceed.
Before one after the other, let's just move on with the numbers 2, 3, 4, and 5.
Yeah, no problem, Honorable Chair. I was just looking at my notes. One question that I want to put forward. Do you believe that having 70% of all the birth, and I think that that was asked by the by Sokacha, do you disagree with the evidence from elsewhere in the world, ranging from China to USA, that fee for a service medicine drives up the cost of healthcare and induces unnecessary service use? Do you believe that the amount of and quality of care, healthcare that someone gets should depend on the medical need or their ability to pay it? How do we ensure that more equitable distribution of health workers and service availability when the prices and the wage paid in the private sector are so much higher than in the public sector? So lastly, Honorable Chair, I want to understand, because the scenario that the doctor would have put down on a Dlamini, I think it does not project the context in which he has presented, that of saying that the current system is a new liberal systems. But what I want to establish is that, does he believe that introduction of national health insurance, it's a neoliberal systems, as he said that in so far as chapter he was referring to Dlamini? Thank
you. Next.
Thank you very much, Chairperson. Firstly, let me welcome the presentation, but also I'm going straight to my question. Ms. Hasha, my first question is that Ms. Hasha accept that implementation of the CAP be done on incremental basis as with all new programs. The second one, Chairperson, is that understanding was that the bill states that NHI will be implemented in a phased approach. What is his understanding of this? What is his view on the fact that the NHI journey started as far as 1928 with Black men in 1944? In his view, does he think that this could be equated as the lab testing NHI implementation My other question is that, do you agree that all South Africans should get the health service they need as per Section 27 of the Constitution? Here also keeping in mind that Section 27 also calls on government to take reasonable legislative and other measures to achieve this. The other one, Chair, is that how is it possible to realize this aim when nearly half of all health spending services, only the 16% of the population that had a private medical scheme coverage? The last one, Chairperson, how can we ensure a more equitable distribution of health workers and services availability when the prices and wages paid in the private sector and also so much higher than in the public sector? That will be my submission for question, Chairperson. Thank you.
Thank you, Chair, for the opportunity. Just to mention that we are aware there is a section of schedules to amend the National Health Act, and some other amendments are also envisaged in the near future. Now, what would our presenters think, or would they have any comments on this section of schedules in relation to the envisaged role of the health districts through the DHMOs? And then to Dr. Friedman himself, he's spoken about the medical legal claims, and we understand it is a challenge, but it is being addressed at the moment by the DOH and by SAMA. And does any view on the manner that it's being addressed, and does he think that it is beginning to bear some fruit in bringing an end to those many medical legal claims, or at least to alleviate that pressure? Thank you.
Thank you very much, honorable members. Let me just add my two. We have listened to other people talking about the asylum seekers having the extreme view of saying, just remove anything about asylum seekers in the bill. Now, you are saying what is in the bill about the asylum seekers is not adequate. Can Dr. Samuru indicate what would be her view? What would she like to see said or done about the asylum seekers there? And the second part, just expanding on the question of by Dr. Jacobs, we say you are wanting to ring fence the NHI funding so that the medical legal litigations do not impact on it. So how do you see that happening? How do you want that structured? Because there will always be medical legal litigations. At best, you can reduce them, but that there would be none. It's probably not possible. Maybe you are looking into that no fault compensation fund. Maybe you could also share some light on that. You might just have some few other questions, but those ones that I've just picked up now, and I was reading through your document again, maybe looking into some, we might come back one or two. Maybe you answer those for now.
Owen, are you speaking? I think you might be muted.
I was just suggesting that you go ahead and then I'll fill in.
Okay, thanks. So thank you, honorable colleagues, for the questions. I think we'll try to take them in the order that you've asked them. So I think Honorable Sokacha, you asked what should be removed. I think in certain places we felt that there might be room for minor amendments just to enable the incremental process. Where new structures are proposed that have not been tested in our context, we felt that putting this in the bill and legislating this at this point in time is really restricting the options, especially for untested interventions. So we felt that leaving this out at this point in time might allow for a more robust approach to deciding what is the most appropriate structure of the health system going forward. So it might well be that what is proposed in the bill, when tested, might be the best structure or the best answer for our population. But without actually understanding it and putting it in the bill now, if it's not found to be the most effective means to provide population cover under the single payer system, then we do stand the risk that we will be mandated by the legislative process to continue with this, even if it's not found to be the most reasonable approach for us. Yeah, and then just to say, yes, we certainly support the principle of NHI and look forward to the progressive realization of universal health coverage. And when we say progressive, we don't mean that it should take the longest time possible, but it needs to take the required time. We feel that hopefully it will be a quick process, but given the current context, we need to plan, I think, a bit more pragmatically. If we consider the green paper on the NHI that was introduced a few years ago, I think there were timelines articulated, and within the first 5 years, which would have been 2012 to 2017, we had hoped to address all the quality issues in the healthcare system. But according to the Office of Health Standards Compliance, we haven't managed to achieve that even many years after 2017. So I just think that we need to be more pragmatic in terms of the timelines that are associated with the bill. And so maybe leaving these things out of the legislative process, documents might give us more flexibility in this regard. Going on to the question by Honorable Manai, I think, yes, so sure, I think it has been well proven that the fee-for-service structure does drive up healthcare costs. And so we certainly support the introduction of a single payer system. I think our only concerns is how it's being introduced and the service delivery platform that is being aligned with this funding process. And in terms of, will it actually work straight away? And here again, I'll refer back to the Constitution and the progressive realization of our healthcare goals. And I think we should be cognizant of that as well. I think in terms of, I think I'll hand over to Owen. The next part from Honorable Manai was addressed to you.
I'm not going to attempt to link this to particular individuals because sometimes similar questions were asked. The question was about the CEO exercising oversight over themselves, and clearly we do not believe in a CEO exercising oversight. We believe in very strong governance mechanisms, and that's why we're advocating that the strongest possible accountability to Parliament be the situation. And the reason we believe this is because with the pooling of funds, if anything was to go wrong with the functioning of the NHI, it would have very, very severe consequences for everybody in society, particularly the vulnerable. And therefore, we cannot afford to have a state-controlled entity such as the NHI failing under any conditions, because that would be a disaster for our health. So we believe in the strongest possible oversight mechanism, and we've actually suggested Parliament. Do we support the bill? Yes, we strongly support the bill and its progressive realization as provided for in the Constitution. Should the service depend on the need or ability to pay? Definitely, the ability to pay should not be a factor, that all people in the country should get the services that they need, irrespective of whether they can pay or not. If they can pay, though, they should pay. And we do support the idea that the wealthy would make a much bigger contribution to the total healthcare system. So hence we support the idea of progressive taxation and possibly, if necessary, surcharges in the form of some kind of medical surcharge, which would be paid by people of high earning capacity. We recognize that there is a differential between the public and private health sector wages, and that our services need to be available equitably for everyone. Is the NHI neoliberal? Definitely it's not. The principle of the NHI is a progressive idea, and that's why, for me, it's puzzling why we would start to use commercial language. If this is not a neoliberal idea, why do we emphasize national health insurance and not universal health coverage? Because surely universal health coverage implies that everybody gets health according to their need, and it has nothing to do with the finance. Well, I should say that the people's ability to pay has absolutely nothing to do with whether they get care. We have emphasized the incremental basis. This is a cautious approach because we want this to succeed and not to fail. And we can only succeed if we build capacity, and we do this in a steady way, in a developmental way, in the way that the Constitution makes provide for. And we think that although there is a phased approach already, it's not sufficiently phased, and we need to be even more cautious than the phased approach. And I think that I would encourage all members to look at the detail. We can't answer the detail in an oral presentation. There's a lot more detail, and obviously, if you want further detail, we'd be happy to make further submissions to provide evidence for what we said. It is a long time since we've made our submission, and a lot has changed since then. Thank you, Chair. That's I think. Sorry, there was the question about the medico-legal litigation. Yes, I think there has been some progress to avoiding this, but I think that progressive countries have shown that it's important to put legislation in place that will help to limit litigation by making a no-fault compensation for everyone. In other words, there will not be the necessity for lawyers to prove that there has been an injury or there has been negligence. Everybody will get compensated. The compensation will be reasonable, and it won't be related to a person's wealth. So I hope that that answers the remaining questions. Thank you, Chair.
Thanks, Owen. I just want to add to Honorable Dlomo's question about asylum seekers. I think, yes, I mean, it is a controversial issue there, but given the situation of illegal immigrants and asylum seekers and refugees in the country and the complexities over the past few years, especially pre-apartheid and within our democratic society, but related to very complex factors, we feel that at this point in time, it would be more relevant to actually afford asylum seekers the same rights that are afforded to refugees in the bill. Thanks.
There is a follow-up question from Honorable Sokacha. I will also hear after that.
Chair, no, I've not indicated a follow-up question, please. Sorry, Chair.
It is me who want follow-up, Chairperson.
Oh, I'm mistaken. I was mistaken. Honorable Munai, yeah.
Yeah. Let me proceed.
Continue, Honorable Munai. Okay, I don't know whether he's struggling with the connection now. I asked Honorable Munai to speak.
Chair, I want to know, Honorable Chair, that we need a presentation, for instance, this is cutting off.
Mr. Mora and Dr. Friedland, if I were to ask, do you feel that in the bill there is an indication that it's going to be a prolonged, not a step-by-step process? I heard you mentioning that you probably don't foresee that. It will be a step-by-step based on our circumstances. Did you read in the bill that there's a different approach to that than what is envisaged as an incremental approach that many other countries have used? Number two, I did not understand very well what you raised about the Office of the Health Standard Compliance, because I see the Office of the Health Standard Compliance as one of the enablers towards NHI. Now, what challenges are you picking up with the Office of the Health Standard Compliance? Because it is the one body that is going to assist us to accredit facilities, their readiness to implement. Now, maybe if you could then go to that and give understanding. But I think another related point with the Honorable Dr. Jacobs is that it is expected that when the NHI comes to effect, it will impact on some other health acts, including the National Health Act. Obviously, there are certain things that will have to give in there, be amended, be changed, be deleted. Do you have a challenge with that approach or not? Honorable Numuna, are you back on the platform?
I'm back indeed. Thank you very much. The first speaker, Honorable Chair, put a very contradiction between the early point of the bill that must be focused on the establishment of the fund, and on her later comments, she raised that the bill must explain what must happen. She must really explain what must happen to facilitate to the facilities that do not meet the standard set by OHS. That is the contradiction she put herself forward. Because really there's clearly a need for her to explain what must happen to facilities that do not meet the standards set by OHSC. Because earlier on, as I said, Chair, she was indicating that the bill must focus on the establishment of the fund, and a later comment, and the latter comment that I just said, these were really two contradictions so far as the early point of the bill, as she indicated earlier.
Okay.
Okay.
Honorable, can you then assist us with the responses?
Okay. Thank you, Honorable Chairperson. I think I'll answer your questions first. And you said that does the bill not imply that an incremental approach will not be taken? And no, this is not explicit in the bill, but I think the proposed structural changes that are very different to the current context and the current organization of the health system suggest that it's not really an incremental approach from where we are now to where we want to be. And I think in that sense, it doesn't really articulate clearly how it would be incremental. I'm not saying that the plan is not to be incremental, but I think from what's articulated in the bill at present, it just seems that there's a dire change in the structural organization from what currently exists. And there's no kind of pathway for how we go from where we are now and where we want to be. And we feel that if we had to do this like within maybe 5 to 10 years, it might not be achievable, but yeah. So just from what is articulated in the bill, I think it just doesn't suggest that the timelines are clearly articulated. And I agree the Office of Health Standards Compliance is an enabler of the bill and the system, and facilities certainly need to be accredited. I think the concern is with what the Office of Health Standards Compliance has actually found in its evaluations and the current assessment of quality of the public healthcare facilities in the country. And with that background, to move to the next step might not be feasible within the short term. But obviously, like the timelines are not visible in the bill, but we think that the suggestion is to move from this bill to the act soon without actually ensuring that we have this baseline of uniform quality of care across the system. So yeah, but just to confirm, it's not an issue with the Office of Health Standards Compliance, nor the findings of the Office of Health Standards Compliance and the implications for how we move from where we are to where we want to go next. And Honorable Manai, yeah, I think early on I said that the bill should be less, should have less detail so that we're not restricted by legislative processes when we are changing the health system structures as we go along to meet the needs of quality healthcare within our NHI funded system. And then later on I said, yes, it's important to understand how we're going to manage facilities that don't meet the accreditation process. And I can see where you're coming from when you say this is a bit of a contradiction. And in retrospect, I think I would agree with that. I think here as well, it's not like a clear line. It's not, I think it's not a direct correlation between the 2 points that I wanted to make. But yeah, I do see a point. But I think what is important is that the legislation not restrict us in terms of being responsive to what we find within the health system and responding to our context when we are implementing a new system or a organization of services that we provide. We need to monitor this and make sure that it is working. And if not, we need to responsibly change where we need to. And to do this, it would probably be better if we were not restricted by pre-existing legislative context. So I hope that clarifies my meaning. Thanks.
And if I can just try to amplify that. So in terms of the legislative process, we definitely understand that there will be changes to the Health Act and to many other acts. In fact, that's what we're suggesting, that this bill become a roadmap. In other words, a philosophical, provide a philosophical view that this country is moving towards universal health care, and it's going to happen as soon as possible. And that because we want to make sure that we succeed, there's going to be incremental legislation and regulations on a continual basis for now, maybe for the next 20 or 30 years. Every year, Parliament should be considering this and reinforcing and tightening or improving the legislation. But in the interim, we experiment, we gather evidence, and where we see that something is beneficial, we move faster. Where we see that something is not beneficial or is causing unwanted consequences, then we stop that. And this is really just advice to what is really a most important piece of social engineering, probably the most important social engineering the country has ever done, because this will create equity in one of the sectors, the most important sectors of the economy, it's health services, giving everybody access to affordable health. It's a huge social experiment which we cannot afford to fail. And as legislators, we want to see this as an incremental legislation which will keep coming to Parliament, tightening up. That is what we are suggesting. Over to you, Honourable Chair.
Okay. No, you have explained yourselves. I'm sure the members have understood where Public Health Association of South Africa comes from, and we will read your documents. Fortunately, the members of the National Department of Health are here and they were listening, and at the time we need them to respond to some of the issues that you are raising as well, listening to the Public Committee. They will do so. We thank you very much that you were able to respond to our invitation, and we are now releasing you. Have a good day. Thanks.
Thank you.
Thank you, Chair.
Thank you very much, Chair.
Honorable members, our next appointment, I'm checking if you can flight it there, Ms. Machalamba, so that we can have a short coffee break if they are available. They usually prepare themselves earlier than that time. Ms. Machalamba, the deans, the dental deans, so that they can
They
go
are
back.
available, Chair.
Okay, what time is it now? It's close to be 20 past. Is it 25 past according to my 25 past? Yes, 26 minutes past. 10 minutes break, honorable members. Can we start at 11:35? What time was it supposed to start anyway? Let's see. We're supposed to start at 11:30, yes. So we are already eating on their time. No, 5 minutes break, 11:30 we start, 11:30. They can start loading their presentation, Ms. Matalamba. We start at 11:30, thanks.
Thanks, Chair. Kwahube nikhona?
Hayi ngathi balele ngathi bangqengqile.
Hayi ayifani naye.
Hayi fani naye nyani.
Mhm. Mhm. Okay, honorable members, I hope we are back with our teas and coffees and nothing stronger than that. Because we have this presentation to listen to another presentation. Can we remove that slide for now? It's very scary. That slide on the that is showing now. Yes. Okay. Okay. Thank you very much. Welcome to a group of leaders that I'm scared of. I'm appreciative that this meeting is taking place virtually. I would not have imagined how I would have been in a meeting with more than one dentist in one room. Because if there's any person I'm really afraid to be next to is a dentist. I mean, it's one thing to get a jab on your shoulder and the palm, it's another thing to get a jab in your mouth. Now, these leaders who are here today are the ones who are doing and teaching other people to do just that to ourselves. Nevertheless, we must learn, they must counsel me how I must not get scared of dentists. For now, I am. To you leaders who have joined us, welcome in making the presentation that you have to make. As your comments towards the NHI, we have allocated 45 minutes or less for your presentation, and then the honorable members will then ask questions based on your presentation for clarity. If I were then to allow you to start, we will appreciate that. I'm Dr. Dlomo, the chair.
Honorable Chairperson, can you hear me?
Yes, sir.
Okay. We are going now to start our presentation. We have no intention of scaring you. I'm Prof. Nemuthandani, presenting on behalf of Oral Health and Dental Schools. Honorable Chairperson and committee members, oral diseases are widespread but poorly addressed. And as you have alluded earlier that you are scared, we do not really intend to scaring the committee members. But international evidence shows that this is a global experience. And having said that, oral health is part of the general health and must be addressed along with other efforts to achieve universal health care for all through NHI. If you look in this slide, this is a very young child, almost 2 years old. This child is having the hope, pins the hope on the NHI, with the hope that this child, the experience that these children have had, it's about rotten teeth. After getting these rotten teeth is visiting the dentist or dental therapist and experience the injection, which you have said you are scared of it. And toothache, removal of teeth, and loss of confidence in the health system, which should be building confidence for them. And at the end, they have missing gap, and all of us will know that children, when they're playing together, anyone that has a different image of missing teeth, they are labeled, and these kids lose confidence at an early stage. And that is the problem that we hope with the NHI, this will be addressed. Oral health team in South Africa, it's made of oral clinicians and non-clinicians. I thought it would be important to take committee members through this because quite a lot of South Africans are not aware of what are the oral health teams and what can they do and why is it in this way. Oral hygienists, who are roughly 1,000 in South Africa, these are the key drivers of primary oral health care. Scale and polish, cleaning of the teeth, and giving the education to the masses of our people. Dental therapists, these are, and historically, those of us who will remember, Blacks were not allowed to do dentistry. It was earmarked for previously Blacks who it was indicated that they have no capacity to become dentists. And the SMU, which was Medunza, was the only dental school that were training dental therapists. We currently have 600 in the country. And these are the people that should be the drivers of primary healthcare services. Dentists, we have almost 6,000 dentists in South Africa, and these are highly skilled people who have the mismatch of doing the services of the other categories that I've mentioned because there are not enough in South Africa. And we do have specialists. I know that at certain time, people only know about the maxillofacial surgeons, but there are other specialists, orthodontics, who make teeth straight. When you see people with braces, these are the orthodontists that provide those services. Oral med and periodontists, these are the people that make sure that when we're in a group, we should not have bad breath and smells from the teeth. And we do have public oral health specialists who are the planners, who are key drivers for NHI if we want to make it successful. Oral pathologists, as the name explains, these are specialists who deal with oral cancer that are associated with tobacco and alcohol abuse. Prosthodontists, these are the people that provide false teeth, dentures, implant, so that we can be able to rehabilitate our mouth and eat, because an elephant without teeth, it dies within a week. For human beings, it creates a myriad of other diseases. Without chewing the food properly in the mouth, acid is released in the stomach, and then you have problem of digestive system and other chronic conditions. Now I'll quickly go to non-clinicians. These are the dental nurses. Those who are medics will know that you will not go to theater without a nurse. You would need somebody to assist you because dental procedures by their nature are surgical. So you will need somebody to prepare the equipment, instrument, and assist you. We currently have very few of them in South Africa that will be able to render or complement the services. We also have dental technicians. These are the people that create or make dentures. They manufacture dentures. Dentists or oral health teams send the prototype to the technicians to make dentures and make the ears and the eyes. These are only 1,050. And currently we only have a very small percentage, 7% of them are blacks, 80% are whites. These are historical information that I think it's important. Dental schools in South Africa, there are 5 dental schools, and this is important because this is where the production of human resource that will be required for NHI should be focused at. We currently have 4.5. And I will say 4.5 because University of Durban, University of KwaZulu-Natal, led by Dr. Muslim, it trains dental therapists and oral hygienists. Then it's followed by University of Western Cape. I've got my colleague here in the team, Prof. Neil Mybeck. They train dentists and oral hygienists. University of Witwatersrand, they train dentists and oral hygienists. University of Pretoria, led by Prof. Shangase, she's part of this team, she's in this attendance. It trains dentists and oral hygienists. SMU, which was formerly Medunza at that time, led by Prof. Hendricks, is the only among the 5 dental schools that is training dental therapists. The other universities, for one reason or another, they have resisted to train dental therapists. University of Technologies, those that are training the non-clinicians, we've got Tshwane University of Technology. They are training dental nurses and dental technicians. Central University of Technology, dental nurses, they don't train dental technicians. It was a mistake to include them. Cape Peninsula University of Technology, they train dental nurses and dental technicians. Durban University of Technology, they train those groups. But of great concern is that irrespective of whatever we are planning for NHI, it will be unfortunate if we don't make sure that there are enough production at different levels. And as the committee of dental deans and managers in the different provinces in South Africa, and I should mention that in the public sector here in South Africa, we only have 8 dental technicians for the total population that we should render services to. And in this slide, we are just saying there's low number of dental technicians that are produced or registered. And at one point, there has been 100 failure rate of Black students through the making of the South African Dental Technician Council. Oral health and dental didn't support the national insurance. And we believe that oral health services will have better funding under NHI. Those of you who are fortunate to have a medical aid, if you are having GEMS, you will know that a family of 7 is covered by roughly 1,600 a year. And that will never make sure that you have better services, except that we are only creating an environment for tooth extraction. Our people, we hope that they will have access to oral health services by making sure that all the facilities, health centers, and I will articulate a slide on that one to indicate the challenge that we currently have. And we believe that NHI will make it simple to have access to these oral health services. We believe that the legacy of the African child who is growing up experiencing the pain and that leaks of standards because they will have injection, it will come to an end. It will not be the service of removing the teeth for our communities. Our elder senior citizens, they suffer for now because they cannot afford false teeth or artificial prosthesis. It's unfortunate that in the system that we currently have, anyone who loses the limb, there is funding for artificial limb for replacement. But those who lose their teeth, there is no budget for artificial dentures for them. And we really, at this point, find that there is a need to make sure that this committee make it compulsory for the former white universities to train dental therapists. It cannot be only the 2 institutions who are training this, the others are training only dentists. And this has to do with the funding system, because dental therapists, as you look for it in terms of the bursary funding system, there are very few who are given this bursary to study dentistry. So that we think it should be addressed immediately. I just had this slide so that the committee members can have a picture of what is happening. If the primary oral health care human resource in the province is in this way, and I will take one particular province for the reason that it has only 2 dental therapists who should be providing primary oral health for the whole population in Western Cape. You've got only 2 dental therapists. Free State has only 1. How is it possible that if we implement the NHI, we would be able to support the universal health coverage for all? So this has to be addressed through the human resource plan, and I'm happy that the National Department of Health has a strategy which talks about changing the training situation where we will have more dental therapists and more oral hygienists. And if I'm remembering it correctly, there is a determination that we should have 300 dental therapists produced per year and 300 oral hygienists. Currently, we have less than 20 or 30 that are produced in the whole of South Africa. There is a shortage to have more of them trained. We further advocate that the national health insurance should be the only funding mechanism for health in South Africa. And this, it means that there should be replacement of all other funding mechanisms. And this committee, we are urging it to take care that they take over from the medical scheme, the NHI takes over from the medical scheme. This committee must repeal the Medical Scheme Act in entirety, as other HPCSA has said yesterday, and all these oral health professionals fall under HPCSA. NHI should focus on the funding and contracting matters. The other matters that relate to practice that will be managed by regulatory bodies that are there. Our proposal with specifics is with regard to Section 25 under the benefit of advisory committee. We are saying instead of having all heads of medical schools, we should have one representative from medical and also one from the dental schools, one from nursing and one for pharmacy and other health programs. We do not see the reasons why we should have all head of medical schools represented in there, because medical schools do not represent the interest of dental schools. This should be very clear to the community. It's two separate entities. And the nature has been that medical schools are representing dentists. It's not that. Instead of having 9 provincial head representatives, have one representative from Health Council and a member of Technical Advisory Committee for National Health. We're also saying instead of having 2 hospital association representatives, we would say we should have one representative of the hospital association, representative for primary health care, and others. Section 27 requires stakeholders advisory committee. This committee is mainly composed of statutory council. We are of the view that it will be significant that we have the voice represented by HPCSA and other associations, council and statutory body on that one. Under the duties of the fund, 5.1D, enter into contract based on the oral health. Sorry, I think it moved faster than it is. The fund must reimburse the healthcare providers and that the providers do not have may not have this service. And this is important specifically with regard to some of the services. How do you cost oral health education promotion? Because the current medical aid system rejects that notion. And we believe that NHI should be focusing about the well-being of the community rather than the intervention of just putting the filling and amalgam. If we want to make it a success, we must make sure that all other promotion measures are put into place and recognized. The benefits of advisory committee, all heads of medical school in the country, I think we have articulated those issues. Stakeholders advisory committee, we propose an inclusion of oral health personnel under the section or D or whatever, because our experience has been that oral health is neglected. Health benefits pricing committee, we propose to have a representative in this committee because dental services by their nature are very expensive. Unless things are ordinarily addressed, we will have a bill that will not be easily maintained. Technical committee, this is a place where we propose we should have an inclusion of oral health practitioners. This slide summarizes what we think NHI will provide a solution to. And I will start with a simple dental case that this woman had a tooth, but there was nowhere where she could get the service. Had we had an X-ray and a dental therapist in a clinic or in a health center, this would have been treated. The tooth that was rotten here, the patient ended up losing an eye. This could have been avoided had we had a functional health system that takes care of its people. I thank you.
Hey, Professor Nematandane, you are scaring us. Now, you need to explain this part of physiology of a dental accident causing an eye accident. Anyway, I will come later. My colleagues, please take this picture away. It's painful to watch, but it's something that you are maybe using it to teach students so that it can remain in their minds all the time. May I, then I haven't checked my SMS in terms of my colleagues who want to indicate to speak. If they can remind me or just shout here, I'll take your names down. I didn't look, I was glued up to this presentation of Professor Nematandane. Who would like to speak, honorable members?
Our chair, thank you.
Dr. Jacobs, you are number 1. Next. They are scared of a, okay. If there's no one taker, I will come after you. Any other taker? Okay, Dr. Jacobs, start.
Thank you. Professor Mutandani, we had met you before.
Yes, yesterday.
Yesterday, yes. I see you wear 2 hats. But thank you very much for this presentation. It is, of course, you've stressed it, very important that people should have good dental health. And you've just shown us what dental caries can do to the sinuses and then even to the eyes and also to the brain, because of course people can also get meningitis and abscesses within the of the brain, and then encephalitis, etc., just purely from an infection with tooth infection. And so this really shows to me the need that we have of universal health coverage. In this case, we're talking about the NHI. And for my ears, just a comment to just thank you that you had actually brought this picture to us. And it really shown to us the importance of getting our people access to all different types of modalities of healthcare and treatment options. And that's all I wanted to say. I just wanted to comment and thank you for that presentation.
Thank you.
Okay, Professor Nematandane, on my side, your very first presentation, you are saying, I would have thought simply sweets and chocolates will give us dental caries, the young ones. But you are actually coming into a very important point that you think NHI will, among other things, remove or reduce the sufferings and what you see on those children, dental caries and all that. I would want you to expand on that part. But number 2, you are tasking this committee to do 2 things probably related to this work. You are saying this committee must repeal medical aid schemes. Now, I am taking that inverted commas was normally we repeal what has been brought to our attention. You need to motivate that, prepare a submission that might talk to this. And maybe I want to check if you don't think that what is written about medical aids in the bill is sufficient enough. You think there is something much more that needs to be done more than what is said there. We'll welcome to hear your comments. You are further tasking this committee to look into, among other things, calling former white dental schools to impress upon them to train more dental therapists. As you showed in your slide there, there's 1 in one province, 2 in other province. I wanted you to help me to understand just now on the current health issues. What is the significance of not having a dental therapist per province or almost 1 like you have? What is it that you are missing in those provinces that you have alluded to? And obviously, lastly, you are such a strong advocate for saying nothing for us as a dental team without us. So you would want to be seen to be in some of these committees that are technically supporting the NHI. I think that is probably what you are alluding to. I'm using my other words, nothing for us without us, but then maybe you can comment on this issue that you are raising. Thanks.
Thank you, Honorable Chairperson. I will request my colleague, Prof. Neil Maybeck, to talk about the health promotion and also the repeal of medical scheme. And on the issue of the dental therapy, I would request Dr. Mtuba to, and any other colleague to comment. Prof. Maybeck.
Hold on, Professor Maybeck, before you comment, I noticed on the platform there's a hand raised under the name of P. Ngwengu. Now, we don't have a portfolio committee member of that surname. May I check who is that member and what is the reason for the hand?
Thank you, Chair. This is, okay. Thank you, Chair. This is Dr. Gwengu from the School of Oral Health, SMU, Sefako Makato Health Science University. Thank you to the nice presentation by the good doctor, Professor Nemotandane. I just wanted to re-echo the fact that the three universities.
Dr. Ngwengu, Professor Nemotandane was allocating people who are going to respond to our questions. You are probably going to be one of them, but can we give him that space to indicate how that is going to be handled?
Yeah, thank you, Chairperson. I think you handled it well. We have Prof. Neil Maybeck, who is going to respond to the question that have been posed. Prof. Neil Maybeck, can you respond?
Thank you, Professor Nemotandane and Mr. Chairperson. I think the main point we want to make, which is not adequately addressed in the NHI document so far, is that for oral health to actually achieve the kind of outcomes necessary to improve population oral health, there absolutely has to be a very clear set of strategies to deliver the dental public health interventions. Here we're talking about fluoride delivery, brushing programs, sugar consumption reduction, and the education around oral health promotion information. Those are the only things that are eventually going to reduce the disease burden. Without this, we are going to have an endless and an unmeetable demand for curative clinical services in dentistry, which elsewhere in the world and here costs a huge amount of money. And in many cases, it chooses people to opt out of getting any treatment because the costs are so high. And in many dental systems, including the US, dental benefits are separately allocated. You have to buy them separately as a top up to a core, any other kind of core medical insurance. So we really absolutely have to get the oral health promotion things in place, and there has to be a way the NHI is able to fund that level of intervention. Otherwise, we are not going to make much progress. That's as much as I want to say there, but it's an essential component that has to be addressed. The second question, Prof. Nemotandane. Okay, I think that's the question you asked me. If there's another one, you can delegate it later.
Tandani is muted. He did ask you another question. Prof. Tandani, you are muted.
Can you hear me?
Yes, we can hear you now.
It was the issue of medical aid scheme. I think the chairperson asked the medical aid scheme, why should it be repealed? Can you address it, Prof. Maybeck?
All right. It's a difficult one to address because the funding of national health insurance is a complex scenario. In dentistry, we also suffer from serious overtreatment and overcharging experiences because of the fee for item. And this came up earlier in the public health presentation. Fee for item is a very problematic and cost escalating measure. So that would be a design change that is necessary. capitation systems have been used elsewhere, and that's one of the options to consider. However, I think the big question is really that the biggest achievement of NHI will be to try and achieve equity of distribution of the financial resources that go into healthcare. Dentistry chews up a huge amount of this, and it obviously shares with the rest of the healthcare system the need to ensure that the skewed distribution, where the wealthy get the greatest benefits because they can afford them, and those are routed through the medical aid schemes, some of that has clearly got to be distributed more fairly across. Abolition of the current form of the medical aid schemes is clearly necessary. But in recent research, looking at public-private partnerships down in the West Cape under COVID, we've learned certainly that the administration of the benefits, payments, etc., requires a very complex bureaucracy. And at the moment, the public sector doesn't have it, whereas the medical aid systems do. So you kind of want to do away with the way the medical aids ring fence their resources, but you want to make good use of the kind of expertise they have for actually responding to claims, paying providers, which is a mechanism which we will need. But maybe that can be rerouted from the medical aids into the new system. We can't have all the money locked up in the medical aids, and that will be the motivation for why in their current form, they have to be removed and reconstructed. Thank you.
Thank you, Prof. Mybeck. Could we have Dr. Mkuba on the issue of dental therapy?
Prof. Nematandane, just hold on a bit. Just hold on a bit before you move on. To our parliamentary staff, you have allowed into the platform some gadgets that are not easily identifiable, and we need to know who was logged into the meeting. I am happy to see a gadget written VETS user, because then that you can actually link up to a leadership coming in from that institution. The following, please, can they be named? A is A00168664. The other one is Galaxy SB or S8, Galaxy S8, and the other one is 004-00108. Please, those gadgets, parliamentary staff must be named who they are. Otherwise, we don't know who is in the platform now. We don't mind if we would know this is a media person, but what is the name of that person, so that you can know who we're dealing with. Honorable Professor Tandane, continue. Sorry for that. You can then delegate further.
Thank you, Chairperson. I would request Dr. Mkuba to address the issue of dental therapy and Prof. Shangase to add on what may have been missed.
Thank you so much, Honorable Chair, Dr. Dlome and Prof. Nemutandane, and parliamentary honorable members. Dental therapist members are part of the primary healthcare services in the dental side. They provide part of the primary healthcare package. Now, if you do not have them in your health service, you tend to employ dentists. One of the cost drivers in the service pricing is the compensation of employees. Now, if you employ dentists to do primary healthcare, you are increasing the pricing of that service, because the compensation of dentists is twice the compensation of the employees for dental therapists. So in provinces where you have less dental therapists, you find that at primary healthcare level, CHC and clinics, you've got dentists that are providing primary healthcare package. That costs more. And at the same time, because of limitation in funding, you tend to employ less human resources to do a huge part, because primary healthcare package or services, they constitute close to 70 to 80% of services, that is prevention and early diagnosis and early treatment. Therefore, in provinces that you have less dental therapists, you've got more dentists, and that service at primary healthcare, it becomes more expensive. So that's why we support the call to have more dental therapists and oral hygienists to provide primary healthcare package. Thanks, Prof.
Thank you. Prof. Shangase, any additional information to add to our honorable members?
Thank you, Prof. Nemotandani, and thank you, Honorable Chair. I do not have anything to add to what Dr. Mtuba has said. I think he covered everything. Thank you.
Thank you, Honorable Dr. Dlomo. If there are any other questions, we will welcome them. Those are the ones that are delegated to speak.
Okay, what happened to that member who is part of you who wanted to speak from Sefako Makgato University?
We would not own what the member will say because it's not what we have agreed. So we remember this is the platform where people are entering to say whatever they want to say.
Okay, let's hear that South African who is going to raise views that are, according to Professor Nemotandani, not necessarily what they have prepared together as dental deans. Let us hear that member.
Okay, are you giving me an opportunity, Dr. Dlomo? Honorable Chair?
Introduce yourself, then you can go to the platform, yes.
Okay, this is Dr. Gwengu from the School of Oral Health, Sefako Makgato Health Science University. My question to Prof. Nemotandane, out of interest, I couldn't hear him mentioning anything in terms of...
You are not asking questions here, ma'am. You don't ask. You don't.
Okay.
It's us as parliamentarians who are asking the presenters, those who have come to visit us, questions.
Okay.
Not
Okay, then let me put it. Okay, let me put it as an additional point. Yes. Okay, my point is the issue of having to address the quadruple burden of diseases, in the sense that you'll experience trauma and injuries, whether we're talking at a primary healthcare setting or we're talking at a hospital-based setting. My interest is the fact that there's a bigger role which is played by maxillofacial specialists or even prosthodontists, in the sense of having to be rehabilitative. To me, it's quite important to also pitch up the role played by specialists, especially at a hospital-based level. Thank you. That's just my input.
To that, Prof, I don't know whether it's Professor Shangase who raised the issue of a dental therapist versus a dentist, that you are like taking somebody highly trained to work at a clinic far-flung there because in that province or in that space, there's an absence of a dental therapist. And in so doing, therefore, you are actually getting, you then end up with less of the dentist because you cannot afford to have so many instead of would have had so many dental therapists. What is the bracket sort of remuneration of each of these specialists or of these professionals?
Thank you, Honorable Chair. I will ask Dr. Mtuba, who was addressing it. He has the information. Dr. Mtuba.
Thanks, Honorable Chair. Thanks, Prof. You find under the current DPSA remuneration, Honorable Chair, the entry level for a dentist is about 950,000 rands per annum, excluding the other benefits. But with the dental therapist, it's about 520, 540 per annum. So it's almost double to employ a dentist. The dentist salary is almost double that of a dental therapist based on what we have on the public sector salaries scales. I'm talking about level 1, let's say OSD 1. Thanks, Chair.
No. Why should we be forced to enter into a debate. Maybe we should. But then, is there a challenge that you think we'll face with our dental therapists? There was an issue that maybe we should look into that. Why is there no appetite for former white dental schools to train dental therapists?
The chairperson, there are two fundamental issues. Number one is that in the past, before we liberated ourselves, dental therapy was only profession for Blacks. And there were very few Blacks who managed to do dentistry. Number two, the cost of training a dental therapist in a university in terms of setting up the equipment, it's the same. But when it talks about the funding from Treasury or Department D head, it's not the same. So it's just like taking a trip with a bus and taking a trip with a taxi. I would spend more by taking a bus with one passenger and taking a trip with a taxi with one passenger. So it's the cost economics. The second thing is public sector. There are no posts for them. I'm indicating Western Cape has only 2 posts for them, post-democracy. Now, even if they are produced in a university, Department of Health has not created the post for them. That is where the challenge is. And if we are going to implement a primary healthcare approach, it will be a disaster to put dentists in a clinic and not have oral hygienists, dental therapists, because at a primary level, the dental therapists and oral hygienists are appropriately trained for that. Dentists are highly skilled officers that should not be running, giving instruction of how to brush teeth and public approach oral health education. That will be a waste of resources. They must be in a secondary or tertiary level where they are now dealing with restorative of functions of teeth rather than doing the primary function. So the universities by their nature have resisted training dental therapists. And that if there is a funding mechanism and a bursary that is allocated more for dental therapists and creation of posts, NHI with regard to oral health, it will be a success.
Hey, Prof, you have been extremely educational to me. I'm going to, in the near future, find if as a committee we cannot invite you to come and educate us even more and maybe formulate this important program for the country, because it is not just about NHI, but it's about easy access. I mean, there's a program in health where we are trying to eliminate dental caries in small children in many primary schools. Because if you start losing your teeth at that early age, then you are unlikely to be a grandfather with a good sense of teeth. Now, that program will be supported by some of the things that you are actually suggesting. So I think we need as a committee to listen to the dental deans, the deans of, to all of them listening to us and maybe reshape the way you are proposing, because you are at the cold face of training these professionals, and you are also at the cold face of seeing services in the country. We will then thank you very much for this contribution, and wish that we can meet in the near future for this other program of educating us and taking this matter even forward. Okay,
Honorable Chair.
you.
Honorable
Yeah.
Chair.
Yes.
Sorry, I was raising my hand. There's 2 issues I want to raise, if you allow me.
Okay.
Yeah, the first thing, Honorable Chair, is that the people that are not part of the, I don't think we need to allow in the future the people who are not part of the delegation to present, because allowing that, people may, hijack the meetings and may really cause confusion to the public hearing. This should not be allowed in the future. But my question is the following. If I can get the position of your institution without ambiguity in support of the NHI bill. Second question is that relating to the dental's dean, the inclusion of the oral health practitioners in all committees of the NHA fund may pose a challenge, Prof, as all professional categories want representation, and we have not done with other professions as such in the NHI bill. This may not be feasible as the number of professional categories are too many to mention. Will it be appropriate if they are included as part of the multidisciplinary team in the regulations instead of the bill? Thank you, Honorable Chair.
We welcome that. We would be happy with that. We just want to make sure that we are not left behind so that things are done properly for oral health.
Chairperson.
There's another hand. Yes, Honorable Kela. Hold on. Yeah. Kela, come through.
Thank you, Chairperson. Firstly, let me agree with you, Chair. Indeed, we have learned a lot from this presentation, and I want to support you that as a portfolio committee, we must have a session with them, Chair. Coming to the question that I want to ask, Chair, is that inclusion of oral health practitioners in all the committees of NHI fund may pose a challenge as all professional categories want representation. This may not be feasible as the number of professional categories may. Will it be appropriate if they are included as part of the multidisciplinary teams in regulations instead of the bill? That will be my question to the presenter. Thank you, Chair.
We welcome it, Honorable Gela. We welcome it.
Okay. Yes, thank you very much. I think what was raised by Honorable Munyai first before he asked this question is only fair. This platform was meant for the dental deans of our dental schools to come and make presentations. It was very unfortunate that there is a person who then was coming in to pose a question to Professor Nematandane, because the protocol here is that we invite institutions, members of the public to interact. We do not invite members to then start asking other members in the portfolio committee about this and that. I think that Ms. Kwengu, you must actually not do that in future. You have other platforms within the institutions where you come from, where you can have that engagement. But this was not part of, and you remember I interjected, immediately you raised it, said, there is Professor Nematandane who made a broad presentation, and I had given it to him to allocate speakers who were going to respond. And you had your hand raised long before I could even complete. And I think let us agree that this platform will always remain an interaction between the institutions invited by us as a portfolio committee and the portfolio committee, and the leader of that delegation will indicate who will answer which question. Let us leave it at that, and I'm sure Ms. Kwengu, you will also share that with the other colleagues that you did err when you came to this portfolio committee by coming in and jumping into the space that was not allocated to yourself.
Thank you, honorable members.
Okay. With that, honorable members, we bring this meeting to a close. Thank you very much. We have another presentation that is going to be coming in now. That's keeping us our toes. South African Human Rights Commission. Yes, that's the last one that we are going to have. I have since seen Ms. Gwengu posting an apology on our chat, and we accept your apology, Ms. Gwengu, unconditionally. Thank you very much, colleagues. You are then released, Professor Nematandane, with your delegation. Isma Jalamba, the next presentation, what time is it starting? 1:30. Isma Jalamba is around. She didn't go to fetch the children this time around. Let me see. Oh, what time is this now? 12:30. Okay, yes. So, honorable members, you are having a lunch for 10 minutes. We'll start at 12:30 instead of 12:25. But the Human Rights Commission can start logging in and be allowed to put up their presentation 25 past. We'll start 5 minutes later, 12:30. This is your lunch space, honorable members. Bring your lunch and listen to the presentation, because thereafter you have not much time. You have to go into the house, into the other mini plenaries. Thank you very much. 10 minutes break.
Afrikaans. Chair, do you understand Afrikaans? I want to ask you a question in Afrikaans.
It's not for me to answer the question. Ask it in Afrikaans, or you want to ask me or ask the presenters?
You. I just want to make a statement. Ek is nou kapot.
Hoekom is jy kapot?
Ek is kapot.
Ja, nee.
Kaput is very tired.
Yeah, this must nog baie vroeg.
Okay.
Just hold on, the last one is coming through now. Honorable members, my coffee took longer than I expected. I'm sorry. But we now have, I suppose we do have a leadership from the South African Human Rights Commission. We are delighted to meet you. Some of us have met you in the different platforms, but to meet you in this platform is actually a part. We would leave it to the leader of whoever is the leader of the delegation to introduce those who are here coming to present to us. We are a portfolio committee of health in the National Assembly. We are taking comments, presentations of those institutions who have requested to make a presentation to us regarding the National Health Bill that is currently with us. I now hand over to whoever is a leader to introduce the members that are with him or her, and then we follow with the presentation. We would like to indicate that you have 45 minutes or less to share your presentation with us. We will then ask the members to interact with you, and the honorable members would like to ask certain clarity-seeking questions, then we'll take it from there. Over to you for now. Thanks.
Good morning, Honorable Chair. Good morning, committee members. I'm Fadla Adams. I'm the acting head of research at the South African Human Rights Commission, as well as a senior researcher in parliamentary and international affairs. At the outset, I must extend an apology from our chairperson, Advocate Bongani Majola. He was unable to join us today. He has an alternate engagement with the Remuneration Commission, together with all our other commissioners. And this is a long-standing engagement which they've been waiting for quite some time. So he's extended his apologies that he is unable to be here, but has indicated that in the event that there is a change or his meeting finishes earlier, that he will be logging in. So if there is any movement on the platform, it's not an unwelcome guest, it's rather our chairperson. I am joined today as well by colleagues from the research team, as well as the chair's office. Just to note that our chairperson's focal area happens to be the right to healthcare. So we're joined today by the research advisor in the office of the chair, Ms. Numisa Willie, as well as Ms. Yuri Ramkisoon, who is the senior researcher on economic, social, and cultural, or economic social rights. I am going to hand over the platform to them. Yuri will be running the presentation. As the committee is well aware, we had submitted our comments in November 2019, and we're delighted to have the opportunity to now address the committee around our concerns on the bill. We have been following the process quite closely from the initial discussion level and all the way through to where it is currently. I am going to permit my colleagues Yuri and Numisa, through you of course, Chair, to be able to take the floor, noting that we have the limited time in which to deliver the presentation. If that is in order, thank you, Chair.
Yes, we welcome you and your introduction. You can move on to do the presentation.
Thank you, Chair. Can everyone see my screen?
Yes, we can.
Thank you to the Chair and the Portfolio Committee for your time today. As Fadla mentioned, I'm Yuri Ramkisoon. I'm the Head of Economic and Social Rights at the South African Human Rights Commission. This submission follows the written submission. Sorry. Okay, there we are. So in 2019, in response to the public invitation by the Portfolio Committee on Health for written comments on the National Health Insurance Bill, the Commission did send through comments. The objective of the bill is to achieve universal access to quality healthcare services in South Africa in accordance with Section 27 of our Constitution, which makes provision for the right to healthcare. It's also to establish a national health insurance fund and set out the powers of this fund, including functions, governance structures, and to provide a framework for the purchase of healthcare services by the fund. It will hopefully create mechanisms for equitable, effective, and efficient utilization of resources of the fund to meet the health needs of the larger population and to preclude or limit undesirable, unethical, and unlawful practices in relation to the fund, its users, and to provide for matters concerned with the fund. In principle, the South African Human Rights Commission supports the bill, including the right to health access, social solidarity, equity, effectiveness, appropriateness, efficiency, and affordability. I think if well administered, the National Health Insurance has the potential to contribute to addressing inequality in the healthcare sector and thereby assist in the reduction of poverty in South Africa. Just to note that the South African Human Rights Commission is mandated by Section 184(1) of the Constitution to promote respect for human rights and a culture for human rights, promote the protection, development, and attainment of human rights, and to monitor and assess the observance of human rights in the Republic. The powers and functions of the Commission are also elaborated in Section 13 as seen in the presentation in the Human Rights Commission Act 40 of 2013, where the Commission can make recommendations to organs of states at all levels of government, where it considers such action advisable for the adoption of progressive measures for the promotion of human rights within the framework of the Constitution, the law, and to take appropriate measures for the further observance of human rights. The Act further states that the Commission must review government policies relating to human rights and to make recommendations. From that, the Commission has specific comments on the bill as it is set out, which I will go through first, and then we will look at more general comments in relation to the bill. So firstly, in terms of basic healthcare services, the Act has not defined what basic healthcare services are. The definition, I think, is important, especially in the light of the fact that reference is made to provision of basic healthcare services. So a definition must be in line with the Constitution as well as accepted international standards such as bodies. And I think a well-defined basic health services, provision will be good for the bill. In terms of population coverage, the bill further limits access to healthcare for asylum seekers in South Africa. It's common cause that it takes a long time to finalize immigration matters for people who are seeking asylum in South Africa, and they are therefore left in an indeterminate state, especially as far as registration for services are concerned. And this is not just for healthcare. But the Commission on numerous occasions raised concern about the slow processing and finalizing of applications for asylum seekers, and in some cases, waiting periods have gone on for a number of years. The Commission notes that Section 4 of the bill unfairly discriminates against asylum seekers and undocumented migrants, thereby unlawfully restricting their right to access of healthcare in South Africa. Section 4 of the bill, asylum seekers and undocumented migrants are only entitled to emergency medical services, treatment, and screening for notifiable conditions of public health concern. Migrant socioeconomic rights have been developed and given meaning in courts. So in Khoza versus the Minister of Social Development and Maulale versus the Minister of Social Development, the Constitutional Court held that equality in respect of economic and social rights is implicit in the use of the word everyone in Section 21 for the right to health, or the rights therein in Section 27, sorry. And in Lawyers for Human Rights versus Minister of Home Affairs, the Constitutional Court that held that when the South African Constitution limits rights to citizens, it clearly expresses that limitation because the Constitution did not expressly reserve the rights mentioned above for citizens. All those living within South Africa's borders are therefore entitled to them. In terms of powers and functions of the chairperson, deputy chairperson, and members of the board, the success of the NHI will depend on, amongst other aspects, good governance. Therefore, the powers and the functions of the chairperson and deputy chairperson and members of the board are crucial and therefore need to be clarified and set out clearly in order to avoid conflict and to ensure the efficient running of the board, particularly in decision-making processes. The Commission is also concerned that the bill does not specify a minimum term of appointment for the board. The Commission is, conditions of service for board members. The Commission is of the view that the remuneration and conditions of services for the board members should be clearly stipulated. This will help protect the board from undue external interference and help guarantee the board's independence. The remuneration of the board should be determined by the Independent Commission for the Remuneration of Public Office Bearers in line with the Remuneration of Public Office Bearers Act 20 of 1998, and this will hopefully guarantee its independence. In terms of stakeholder advisory committees, the Commission humbly requests that it be part of the Stakeholder Advisory Committee in terms of the monitoring functions of the Commission. Appeal Tribunal, the Commission feels that there should be independence of the Appeal Tribunal from the board to ensure a rigorous process of appeals. Concentration of power with the Minister of Health. The Commission is concerned with both the appointment process of the board and its reporting lines. The proposed governance structure places concentrated power on the minister and does not adequately ensure the independence of the board, which is essential given its extensive powers in relation to the fund, including strategic purchasing and buying and selling of property. Registration of users. The Commission is concerned about the requirements of birth certificates or ID documents. There are many South Africans who do not possess any form of positive identification, and this requirement will limit their access to healthcare as they won't be permitted to register as users. Also, the section fails to take into account the plight of stateless people living in South Africa who do not possess any form of identification. The Commission recommends that the state considers other forms of positive identification. Alternate means may include proof of residence, affidavits, and will further constitute less restrictive means in limiting the right of access to healthcare services, while simultaneously constituting reasonable measures in progressively realizing the right in terms of Section 27(2) of the Constitution. The relationship between the Minister and the CEO. The Commission notes with concern that Section 21 of the bill establishes a relationship between the Chief Executive Officer or CEO and the Minister, even though the CEO is accountable to the board. The Commission is concerned about the separation between the political and operational spheres of the fund, and the lack of separation may weaken the role of the board. So the relationship here needs additional clarification. The operation of the fund. The Commission notes that the NHI provides for a single purchaser of healthcare services based on population needs. The Commission welcomes this approach as it allows the fund to ensure that it purchases services at a lower price, and because it allows the fund to control healthcare spending and diverts healthcare resources to the needs of the greater population. This in turn allows for greater efficiency in healthcare expenditure and limits fruitless and wasteful expenditure. I think more work would need to be done on the packages of services offered, but that's a broader discussion. However, the following will still need to be clarified. The role of contracting units for primary healthcare, district health management officers and their reporting lines, the difference between a district health management office and contracting units, and the accreditation and funding of ward-based outreach teams. It's unclear what benefits or packages for users will consist of, and transparency and access to information on this is essential to understand the extent of cover users can expect. I think it's also important for an awareness campaign for users to understand what alternatives they have in the event that they require medical care that is not covered by the package of services. Information Platform of Fund. The Commission notes that Section 44 of the NHI requires healthcare providers to keep patient information, such as information relating to patient health. The Commission is of the view that the NHI does not adequately address current challenges with patient record keeping, so it is not clear how patient records and biometric information will be stored under this new system and how it will be collated. Also, issues of confidentiality need to be addressed. These are the general comments on the NHI. An accessible, effective, efficient, appropriate, and adaptable healthcare system that provides quality healthcare services to its users has the potential to significantly reduce poverty and inequality in the country and reduce the wastage of invaluable resources and capacity, which is desperately needed in the public sector, particularly at the primary healthcare level. The NHI aims to address these socioeconomic injustices, imbalances, and inequalities of the past. However, it's important to note that even under the current system, these socioeconomic injustices persist and severe inequalities remain. The current public healthcare system is beset with systemic issues, which were further highlighted during the COVID pandemic. The Commission often gets complaints in relation to health. These include a lack of accountability in the healthcare system, long waiting times for users of the healthcare system, medicine stockouts, particularly at primary healthcare facilities, poor management of facilities, including infrastructure, poor staff attitudes, poor access to information, particularly on the care of family members. The NHI will not automatically solve these issues. These issues need to be addressed now, prior to the NHI, and during the implementation of the NHI. It's essential. Much upscaling of resources and capacity is required prior to the implementation. In addition, strong leadership and governance, multiple checks and balances, and transparency is needed. A clear, more streamlined NHI and fund, I think, is required to the one proposed. The current structure seems quite onerous, and it either needs to be streamlined or more clearly outlined to users, to the public, and to stakeholders in the sector. And finally, in the implementation of the NHI, there are going to be budgetary concerns for the system. It is essential that no retrogressive measures must be applied to any other socioeconomic rights in an effort to fund the NHI. I thank you.
If I may.
Hello.
Hi, Chair. It's Fadla. It's just to say thank you to Yuri. That is our submission from the Commission side. And we avail ourselves to question and answers. Numisa is also on the platform to respond to any questions, and where there are very specific issues which we are unable to respond at this moment, we are happy to send our responses in writing as well. Thank you.
Okay. Right. Honorable members, I did not see on my platform if there are hands raised. I noticed one. Honorable Kwahube, you are number one. Members, may I check in my system, or if I haven't checked, can I get other names of other members?
My name is there, Honorable Chair.
So Kacha, you are number two. Let me just check again. Okay, Honorable, I raise my hand. Munyai, you are number three. Number 4 is Honorable Kela. Oh, so
I was number 1. Hey, Chair.
Yeah, no, ngibonisa phezulu. Yes, shame. You were number 1, now I make you number 4. Ukwakubu wayiveza kwi platform. Ngifunde late. I read the message late. Do you mind if you are number 4, Kela?
No, it's fine, Chair.
Okay, let's take this order. Number 1, Kwahube. Number 2, Sokacha. Number 3, Munyai. Number 4, Honorable Kela. Any other number? Any other name? None. I will be number 5. Thank you. Start, Honorable Kwahube.
Thank you very much, Chair, and thank you to the SAHRC. I'm quite interested. I thought that it wasn't quite fleshed out as well. I would have liked to. In particular, the elements that they have identified around the independence of the board. I know that obviously, good governance models are something that the Human Rights Commission is concerned about, because ultimately that's what gives rise to whether or not human rights are upheld. So I would like some clarity on, firstly, what the actual concerns are around the independence of the board and that governance relationship, and then also in addition what they envision, what the governance model could look like. Because I think it's also important for us to hear from the entities what are some of the suggestions around these things, so that when we do look at all the comments, we can incorporate when necessary. Thank you.
Honorable Sokacha.
Thank you very much, Honorable Chairperson. Let me also welcome the presentation from the Human Rights Commission. Just one question, Chair. Should detailed implementation issues be prescribed in the bill or in the implementation plan? One of the reasons, Chair, for the massive challenges with the US Affordable Act was the inclusion of detail in the bill. Should we not avoid that? What is the thinking of the Human Rights Commission? The detail, should we include it in the bill or in the implementation plan? What is your view of that? Thank you.
Honorable, I think, Munyai. There, or no, maybe I'm mistaken. May I just pose some of the questions, ma'am? One, thank you very much for your presentation. We really appreciate that. And that issue, which will also take up the Department of Health, the basic health services, what's the package thereof. You are coming in with the thinking that the asylum seekers have got what some of us call a basic package of services. I don't know how you'll deal with some of the South Africans who are even saying remove anything that talks about asylum seekers in that, so not even limited. Now, we are coming in from that type of a listening. You could then maybe comment, but I find this to be a bit challenging. A birth certificate, an ID document, is the only document that helps you to even access social services that you have in the country. No person will get a grant until and unless they have that document. And there's not been any issue raised by the Human Rights Commission to say we have discriminated against that group of people who came and requested support of the grant without an ID. You obviously won't vote in the country if you don't have the document. Now, you are not specific as to what other forms of identification should they have, so that you don't leave out any other person, because I don't know the proof of residence, how you prove that, maybe with a letter from the councillor. But I wanted to share with you another story that says in Limpopo currently, there are people in Africa who will come in and access a health service at clinic number 1. Because we have a poor system of identification, on the same afternoon, that person is going to actually access services at clinic number 2. The next morning, before the person crosses the border back to where the person comes from, will go to clinic number 3 and access a package of services that otherwise were meant for one individual and for one illness. Now, already that is showing us that the present, this thing that the department is doing to actually begin to get me to identify a particular clinic where I'm getting services and where it could be networked in the country is the way that should be followed. Now, if you are saying any other form of identification, please assist in that regard. One, I was going to add that in terms of, don't you think that some of the things may probably come in regulations than on the actual act? I may not be specific, but to leave out all issues. It's when the bill, I think I did come across a statement that says the board members will be appointed for a term of 5 years, renewable ones. Did you not pick that up, or maybe you don't agree with that, which is in the bill? I now notice that Honorable Munyai is on the platform. Can I allow him also to ask?
Honorable Chair, I want to really get the clarity as to when they said that the fund is so complex and confusing. What do they mean? You know, because on the funding, can they please advise which section says implementation of NHI will be disadvantaging other essential programs, especially on the bill, because we want them to raise issues specifically on the bill, because anything outside it would be just a fantasy. But let's also go to look as to, can they really indicate what is the difference about NHI fund to other Schedule 3 entities? I think you covered that, Honorable Chair. But let me also want to raise the following issue, because, I mean, why is the presenter saying that there's no term of board? Because you have clarified that issue, because the section 13.5, which state that the board will be appointed for term of 5 years, I think you covered that, Honorable Chairperson. I heard you trying to deal with these particular issues, because I think the Human Rights Commission, they must also help us whether they are comfortable with the current status quo of 2-tier systems of healthcare, one for the rich and one for the poor. I'm raising these fundamental issues because huge money, almost 16% of the money that's available, they are going for the administrators of the medical aid scheme. Are they comfortable that as a human rights institution?
Yeah, Honorable Munyai, when he completes, he just go boom. So I take it that he has completed now his contribution. Okay. Commissioners, you can now respond. Thank you.
Thank you, Chair. So if I can take the first question on the independence of the board and good governance. Our concerns in relation to are in relation specifically to the independence of the board and that it be ensured. We are not raising concerns. We can't raise concerns on the functioning of how the board is functioning at the moment, because it's obviously not incorporated. But our concerns stem from engagements with other departments or other entities that also have boards that function in a specific way. elaboration on how we could see the board, I think we'll have to get back to you once we engage with commissioners, and we can provide that information to you. But I think what our presentation was saying is that we need clarity on aspects of how the board will function, particularly in relation to the relationship with the minister. Is it just the minister who will be appointing? Will it be a panel or the minister alone? Does the portfolio committee have any role in monitoring the appointment of the board or the board itself? So I think we just needed clarity in response to that, but we could give a written response in relation to that particular question. Details on the implementation of the bill can be in a plan of action, but I think it then needs to be made clear that this will be specified at a later stage. It will all go into a plan of action so that stakeholders who we engage with, we can then say to them, well, all of this will be ironed out in a plan of action and not necessarily in the bill itself, which is often common practice with other bills as well. How do we deal with South Africans who say that asylum seekers don't deserve basic services? I think that's a constitutional matter. The Human Rights Commission stance on asylum seekers is they require our help, and they are human beings too, entitled to rights. And I don't think that they will be provided with basic services. There are additional services which they would require, which I think that the NHI should provide for. People without IDs. So it's important to note that we also get complaints on people who battle with identification and accessing the grants as well. So we get complaints in relation to that. And we are working with the Department of Home Affairs to solve those issues. But occasionally, and I'm hoping it will be, not as often as it was in the past, there are people who will not have adequate identification. Now, I'm not saying you can use any alternate form of identification. I think there maybe needs to be some allowance, even if it's for a set period, to allow for alternative forms, not all forms, but perhaps an affidavit or a proof of residence. And this is something hopefully that the committee can consider. And if you require further guidance on that, we can provide a written submission from our head of our equality unit, Dr. Chanel van der Berg. In terms of accessing various packages of services at different points, that could happen, but our studies show that it doesn't happen very often. It's quite a small percentage, or it rarely happens where someone accesses various points of services, multiple times within a day. It's a small percent, and within a range that is even done internationally, and somehow I'm not sure we can work our way around that all the time. You're going to get those few people who do it, but I think on a whole, the percentage is not very high. Yeah, so it says the board members will be appointed for a maximum of 5 years. So we were just curious as to how it's decided. We essentially just needed clarification on how it will be decided whether a board member sits for 2 years, 1 year, 3 years. Is it on the availability? Is it, how is that decided? We just required clarity on that. When we say that the structure is complex, so I've got a detailed drawing of how I see the structure, and I think that to some extent it is complex when you look at who the CEO reports to in terms of the board. Then you have a chair, deputy chair, and then it gets a bit complicated when you get to your the buying units, people who are going to be buying services, and how that relates to Office of Health Products, procurement, contracting units. And so what I'm saying is the structure is not unworkable. I think my point was we just, we need clarity somehow when the bill comes into effect, when it becomes legislation, so people understand how the structure works. Because the more information people have, the better the fund will work and the better the system will work, because people will then know how to engage with the system. We engage with our own stakeholders on this bill, and it was confusing to many of us, and it requires, much interrogation of the bill. So I'm not saying this to be antagonistic. I'm just saying that I think we will require clarity around how the different processes work so that it can be, most effective. In terms of, are we happy with the two-tier system? Of course not. The Human Rights Commission was never, ever happy with the two-tier system. It just doesn't make sense for South Africa to have a two-tier system. The majority of the resources of the country are being spent on a system that only serves 10% at most of the population, in fact, even less, while, our public health system is overburdened. So it's not a sustainable system. And I think I said at the outset that the Human Rights Commission, in principle, agrees with the NHI. And it's important to note that when the South African Human Rights Commission made its submission to the International Covenant on Economic, Social, and Cultural Rights, we pushed for the timiest and quick adoption of the NHI for that particular reason. And the committee actually took on our recommendations. So no, we are not happy with the two-tier system. It's important to note that our comments come from a place of, wanting the system to function optimally, and we're here to work with the portfolio committee. Thank you.
Ms. Ramkissoon, please, we need to section, I think, what section is this one? On the issues of appointments, I think it's section 13. It says the board members shall be appointed for 5 years, renewable once. Now, we need to know what is the challenge. What would you like to be clarified? Because you probably would then help us to understand and package that to get the department to answer that issue. Is on section 13, subsection 5, that where it is actually stipulated that way. But I noticed another follow-up from Honorable Dr. Jacobs, and then we'll take other.
Chair, I was number 4 and you skipped me.
Chair, I'll appreciate to make and follow up. There's one thing that's very urgent.
Honorable Geller never asked a question. No, so no. Honorable Geller, please. I'm so sorry. After Munyai, I came in and I jumped you. So it will be Honorable Geller, and then Honorable Dr. Jacobs, and a follow-up that I've already done, which was clarity, and then a follow-up of Honorable Munyai. So sorry, Honorable Geller. Start.
Thank you, Chairperson. Your apology is accepted. Chairperson, my question will be on undocumented migrants and asylum seekers. What proposal are you making on how their healthcare be funded in an environment unprecedented in towards immigration into the country and limited resources? What is your suggestion based on on international best practice on how other countries have gone about doing this, including on what role SADC and AU or UN could play? Thank you, Chair.
Thank you very much. Honorable Dr. Jacobs.
Thank you, Chair. I've noted what the presenter was talking about in terms of whether details should be contained within the NHI bill, or whether it should be within implementations plan as we go forward. It should just be able to give us some clarity on that, because she does speak about there being an absence of detail on certain respects, and whether she would exceed the detail would still be brought forward in terms of the implementation plan of the NHI. Thank you, Chair.
Thank you. Honorable Munyai.
Honorable Chair, one follow-up that I want to make is the following. Does the Human Rights Commission or they are not comfortable with current state of government that a voted and appointed minister by the president cannot do this appointment, but the minister does this appointment through the cabinet. This is current practice. Why the NHI should be an exception on this regard? The other follow-up, Honorable Chairperson, I'm saying that the Human Rights Commission, for instance, Honorable Chair, I'm sure they'll be very concerned about the inequality, of the current status quo of the people that are excluded, majority of our people, poor people that are excluded from the medical scheme, which NHI is providing an alternative to include everyone, regardless of unemployment status or employment status. So won't the Human Rights Commission or commissioners be explicit whether they support NHI, which address those kind of structure?
Chairperson.
Yes, Honorable Kwahobe.
Do you mind if I just have 2 seconds here?
Go on, follow up.
Thank you, Chair. I think Chairperson, I think we as members have to be careful to receive the comments that we get from the entities for what they are, but not seek to have them as points of debate. I mean, I find the question whether or not the HRC has confidence in the minister as being neither here nor there, but also it's inappropriate. Ultimately, they've put together comments that we as a committee outside of this process will consider. Surely we should not sit here and debate the entities and some of the things that they have to say. Thank you.
Okay, let me not allow a debate on that. I will leave it to the Human Rights Commission to answer, but will not go back to it. Thank you. Human Rights Commission, please.
Thank you, Chair. Thank you, Chair. So the research advisor to our chairperson, Nkumisa Willie, would like to take a few of the questions, and then I will address what she hasn't. If you allow me, through you, Chair.
Welcome, Babu Majola. We noticed that we have finished your other meetings and you have joined us. If you can just show your face on the platform, so that we can warmly welcome you. We did receive your apology that our meeting was number 2 in your priority list. You had number 1 that you have just finished.
Thank you very much, Chairperson. I really appreciate the fact that you accepted my apology. It was a meeting with people that couldn't shift, unfortunately. But I'm pleased that the meeting is going on, and thank you very much for inviting the commission.
Okay, thank you very much, as Ms. Ramkisson has indicated, then we can get the questions answered, but we will still welcome your closing remarks, Bab Majola, when we exit, probably in the next 15 minutes. They are answering the second set of questions now, thanks. Clarity-seeking questions, then.
Good morning, members. As my colleagues have said, my name is Numisa Willie. I am the research advisor in the office of the chairperson. I think for me, what I would like to deal with firstly is the issue of the terms of the board. And if you would look at our submissions in 3.3, we do acknowledge the fact that the Act says that the board members are appointed for a term not exceeding 5 years. Our issue is that there needs to be a creation of security of tenure. This, it says not exceeding 5 years, but what does that actually mean? Does it mean that the person is appointed for a year? Does it mean that the person is appointed for 2 years? So our concern is that in order to create security of tenure, there needs to be a clarity on the minimum term that a person can serve. And that is why we recommended that each member should serve for a minimum term of 3 years to achieve the highlighted objectives that we speak of. Also, I would like to highlight the fact that the Human Rights Commission is enjoined by the Constitution to work with organs of state and to advise them in terms of policy and any other matters relating to human rights. And to this purpose and objective, we've done that. We've worked very closely with the Department of Health. We've worked very closely with the MECs of the different provincial governments, and we've, through our monitoring, we've written reports to them where we give recommendations on how we think the health services can be improved and how human rights objectives in the health services can be provided. We have a Section 11 Committee on Health, which consists of experts in human rights and various human rights fields. We have one on mental health, and these experts also give us recommendations and give us advice, which we do provide to the Minister of Health and also we provide to the MEC. So we are always open to assisting the Departments of Health and the government as such, because that is our mandate. And I think I would also like to touch on the issue of undocumented persons. The issue of undocumented persons is a very political issue because it does not only touch on South Africa's international obligations, but also in South Africa's constitutional obligation. As the Human Rights Commission, we've written a number of submissions on how undocumented persons can be assisted and accommodated in order to make sure that South Africa achieves its international obligations. We've made these submissions and we're able to resubmit them to the committee if the committee asks us to do so. But I think it would be a very lengthy process for us to now delve into the international best practices and what the role of the SADC and the AU could be. So if the chairperson allows us, we're more than willing to submit written submissions on this. Thank you, Chair.
Yeah, Ms. Ramkissoon, any other additions?
I accede that, and I think the Commission accedes that the details of the implementation of the NHI will be documented in further the plans of action. And also just to note again that the Commission does unequivocally support the NHI. Thank you.
We don't doubt your statement. We would just want to give this last to the chair. I was saying, Baba Majola, it's very nice to meet you in a different platform than what some of us are used to. You used to come in to be equipped by you, of course, on behalf of South Africans for certain things that you pick up as challenges. But we welcome, firstly, that you are actually an entity in the country that is doing the work it is doing, that you requested to have a submission to us. And we have also honored that to come and explain some of the issues. We will still want to engage the department, raise all the things that they have been raised by yourselves. But we'd like to, as we close, welcome you to give your closing remarks on this platform. Thanks.
Thank you, Honorable Chairperson and honorable members of the Portfolio Committee. And once more, thank you very much for giving us this opportunity to come and address you on the National Health Insurance. I am not going to repeat what my colleagues have said or may have said, but I would just like, as a concluding remark, to say that the government has done a lot to grant access to healthcare to many of our people. But part of my job or our job is to go around and see on the ground what is happening, whether it is in the rural areas of Cala in the Eastern Cape, or Singa in KZN, or in the northernmost part of Limpopo. We've been there following up on the level of access to healthcare. And I must say that the National Health Insurance should come with a promise and keep that promise that there should be actually universal access for everybody, because right now there are communities that are really struggling to have access to healthcare. And I worry also about the many facilities that have a problem with the very poor infrastructure, that makes it sometimes difficult for people to have access to healthcare. We've been to places where the infrastructure is so poor that when it rains on patients and so on. I'm just mentioning examples without trying to say the situation is bad, is too bad, but I'm saying to the Portfolio Committee, our people have high expectations now that we have spoken so much about the National Health Insurance, that we actually have to rise and try to meet those expectations. The Commission fully supports National Health Insurance and will do everything we can to ensure that it works. But Chairperson, we need to work hand in glove with government because that's the only way in which we can achieve this dream. Thank you very much once more. We remain available. Should the Portfolio Committee need additional information, we will make ourselves available. I'm really sorry that today was a very difficult day for me because we had confirmed this and couldn't change it. Thank you very much and all the best.
Okay, thank you very much. We will now release you and wish you well. We will continue soldiering on with the task that lies ahead of us. We also wish the same as a very important organ in the country doing the work that you are doing. Thank you very much. You are released with your team. Can honorable members remain in the platform for now as we let our guests off the platform?
Thank you, Chair.
No, honorable members, I will request that we log in early tomorrow and avoid the request and not accede to the request that has been made, because there are other people in the platform other than the members and the staff. There are other people who have been invited to stay with us the whole day long, and because they want to actually get this news. So I would really request that the member who touched base with me can speak to me outside this platform, and then we can have this meeting early tomorrow. I will indicate in the platform how we can have that meeting. There are people who remain here, maybe something that needs the staff, maybe not. Rather, let me hear from the member first, and then we can deal with the issue in the meeting once I have able to hear what the member wants to say, because there are people in the platform other than the portfolio committee members. Okay. Tomorrow, this was our last presentation. Ms. Majalamba, can you just remind us again, we are meeting tomorrow, Thursday, but there are other programs, party caucuses. What time are we starting tomorrow? Just to remind the members.
We are starting at 1:30 tomorrow, Chair, due to party caucuses from 1:30 to 4 o'clock because of a basic education mini plenary. Thank you, Chair. We are meeting with the NHLS and the MRC.
Yeah. Can members start logging in at 1 tomorrow so that I will be able to share with them what the member here on the platform wants to discuss? That will be before we are joined by other people who probably may be coming in specified for that presentation. So we can deal with that in-house matter first, and then we take it from there. Ms. Majalamba, you'll open the line maybe as early as 1 o'clock, and then we should then be able to log in and deal with the issue that I'm going to hear now from the member, what we would like to discuss. Thank you very much.
Thank
the
you.
meeting is adjourned until 1 o'clock.
Thank you, Chair.
Thank you very much.